So good evening all and welcome to Jharkhand Ophthalmological Society's webinar on preferred practice pattern in cataract surgery. We all know that though cataract surgery has progressed by leaps and bounds, there are still unanswered questions and not so well-defined concepts. From an absolutely practical standpoint, this session in a panel discussion format with a very stellar discussants like Pandav Sir, Rajan Gupta, BP Kashyap, and of course the most eminent phaco cataract surgeons on board, Dr. Harshul Tag, Dr. Arup Vomik, Dr. Ayun Mahanta. So this is going to deal with the dilemmas faced by the practicing ophthalmologists. And today we are going to cover few complex situations in phaco-cataract surgery. And the constant endeavor of all these webinars are to deliver some take-home points to the attending ophthalmologists. So welcome all. So over to Dr. Sunil Kumar for introduction of our eminent guest speakers.
Oh,
We are sharing slide
thank
from
you, ma'am.
here.
Yeah, thank you,
Yes.
ma'am. So I welcome all of you in
Dr.
this
Sunil Kumar,
webinar.
let me introduce yourself.
Yeah,
So Dr. Sunil Kumar is the Rio RIMS HOD and Jhos ARC chairman, and he's going to introduce all the aspects of cataract surgery.
some network issue, I think.
Our first speaker is Dr. Harshul Tak.
Okay, ma'am. So good evening, everyone. So I welcome all of you in this wonderful webinar, that is the PHECO in complex situation. So we have the eminent guest faculty today. So first I will introduce none other than the Dr. Harshul Tak. He is the PHECO in refractive surgery, Pradeep Rawat Eye Hospital. He is a Jaipur-based gold medalist phaco and refractive surgeon, specialized in advanced cataract and complex eye surgery, known for his expertise in managing the challenging cataracts and innovative surgical techniques. He is a prominent ophthalmologist, and we all know he is a musician and badminton player. He is specialized in the phaco emulsification and refractive surgery, and his expertise in the management of the especially complex cataract and rescuing the extended capsular axis. We all know many of his innovations, we will see, and he is affiliated with the THR Jaipur as of February 2025, and he achieved many awards and oration. So I welcome Dr. Harshul Tak to this webinar.
Uh,
So
at the outset, I'd like to thank Dr. Bharti ma'am for inviting me for this webinar, and thanks to entire office
Dr.
bearers of.
Harshul,
yeah, I will introduce next speaker also. Yeah. So ma'am, next slide please. So the next
yes.
speaker with us is Dr. Arup Vomik. May I have the slide please? He is the senior consultant cataract and refractive
Dr. Arup
services.
Vomik.
Yeah, he is the senior consultant cataract and refractive services, Desai Hospital, Kolkata. And the expertise includes the cataract, refractive surgery, diabetic retinopathy, glaucoma, color blindness, Usher syndrome, ARMD. He is a specialization in every branch. And he has so many awards and recognition in his name, like Dr. KP Rai Award, the grand prize in the best of the best for his video, ASCRS Boston 2010, the runners-up awards, and so many awards. So I welcome Dr. Arup Vomik sir to this webinar. And the next speaker with us is Dr. Ayan Mohanta sir. So may I have the slide of Dr. Ayan Mohanta, please? He is the senior consultant cataract and refractive services, again Desai Hospital, Calcutta, and is again the national figures, we all aware of him. So welcome Dr. Ayan Mohanta sir.
Thank you very much.
So next I will, should I introduce the discussant also, ma'am?
Wait. Yes, as a Pandav sir, because Dr. BP Kashyap has not joined till late now.
Okay. So it's my privilege personal honor for me to introduce Dr. Pandav sir. Is my teacher and mentor as well, and he is currently the professor and head of the Advanced Eye Center, PGI Chandigarh. And you all know he's the specialization in glaucoma management, and he's a leading ophthalmologist based in Sector 2012 Chandigarh with expertise in advanced glaucoma treatment research, and he is instrumental in establishing the comprehensive glaucoma services at PGI Chandigarh. So welcome, Dr. Pandav sir. And our next
Next,
discussant is Dr.
Dr.
BP
BP.
Kashyap from Jharkhand. Yeah. So we all know Dr. BP Kashyap is the ex-president and ex-secretary Bihar and Jharkhand Ophthalmological Society. He is the member managing committee of the AIOS. He is the president International Society of the Manual and Small Incision Cataract Surgery Jharkhand chapter. He is the pioneer of the phaco cataract surgery in Eastern India. He has participated in many cataract and glaucoma life surgery workshops all over the country. He also did the first corneal transplant of the Bihar and Jharkhand combined in 1995 from the local post-tumor site donation. He also established the Kashyap Memorial Eye Bank along with Dr. Bharti ma'am, and is one of the most active eye bank in Jharkhand. He also presented many scientific papers on cataract and glaucoma surgery in so many conferences of the national and international across the country. So welcome Dr. BP Kashyap sir in this webinar. And our next discussant is, next slide please.
Yeah,
Yeah.
yes,
So
please be short.
yeah.
Uh,
Yes. The next discussion is Dr. Rajan Gupta, is the phaco-refractive surgery surgeon, and the skills include so many surgery, phacoemulsification, monofocal, trifocal, IOL, LASIK surgery, pentagram, and so many. And is affiliated with the so many societies. So welcome Dr. Rajan Gupta sir in this star discussion in
yes.
this webinar. So thank you, ma'am.
Yeah. So now we have a quick introduction of our discussants. So we have Nitin Dhira. He is with us the discussants. So he is ISO CSC, and Dr. Rashmi Rana. She is from BCCS, the Central Hospital Dhanbad. Then we have Dr. S.K. Mitra. खत्म हो गया? We have Dr. S.K. Mitra, the ex-secretary Jhos, Dr. Sunil Kumar, already introduced him as the Jhos ARC chairman, Dr. Vinay Gupta, he's the Jeevan Jyoti Eye Clinic Greedy, Dr. Bharti Sharma, she is the head, TMH Hospital, Jamshedpur, Dr. Ajay Gupta, he is the secretary, Jamshedpur Ophthalmological Society, Dr. Indranath Prasad is a very high volume cataract surgeon from Ramgarh, Dr. Harish Kumar, he is from BCCL Dhanbad, so, and Dr. Filpi Pal, she's a high volume cataract surgeon and she does a lot of public awareness activities. Dr. Bharat Singh is from CCL. Dr. Shruti Hegre does a lot of research activity from Jamshedpur and is our LDP candidate from Jharkhand. Dr. Mala Verma, our treasurer. Dr. Mukesh Kumar, our joint secretary. So with this, we start our webinar. And the first speaker is our star speaker, Dr. Harishul Tag.
Thank you so much, Bharti ma'am, for
Harshul
your
Tag,
kind
can you
invite.
present?
Yeah, and thanks to entire office bearer of Jharkhand Ophthalmic Society. It's a great pleasure to be amongst all of you. So I'll be first showing you a case of posterior polar cataract. Is my screen visible to all of
Yes,
you?
sir. Yes, sir. Visible.
Okay. So as we all know that these kind of posterior polar cataract, which have a bullseye appearance like this, they are really very dangerous because the posterior opacity which is there, posterior plaque which is there, it's tightly adherent to posterior capsule, and there are high chances that the posterior capsule opens up when this central plaque it comes off. So all our strategies are focused on trying to keep a closed chamber, not to cause fluctuation in anterior chamber, and we don't want it posterior capsule to open up early in the stage of surgery so that we have maximum amount of nucleus, cortical matter, and everything out. So the sizing of capsulorhexis is very crucial. We don't want a capsulorhexis which is more than 4.75 millimeter in size because in these kind of true posteropolar cataract, whenever the posterior capsule opens up, it's almost through and through like this vertical or horizontal split which happens. And in those cases, if you're not able to find the edges of posterior capsule, you can't put IOL in the capsular bag. So you need to put a three-piece IOL in sulcus and do optic capture. And for that, you need a capsular axis which is not large, not more than 5.25, because if it's larger than 4.75 or 5 millimeter, you can't do optic capture. Very limited hydrodelineation should be done, and no cortical cleaving hydrodissection in these kind of cataract. And after that, I go ahead with the phaco, and you just try to divide the nucleus. And once you have first division, you don't want to cause much of lateral separation of pieces, and then turn the bevel to one side and try to take out a piece of nucleus like a cake, and turn on other side and take out other piece. So the idea is to cause a layer by layer separation. So first the endonucleus, and as we are proceeding ahead, this nucleus gets separated, and you can, without kind of rotating it, you can easily take out this endonucleus. And once you take out this endonucleus, now what remains is the epinuclear bowl. So you first try to loosen up this epinucleus bowl from all around, and don't try to take this central area in the beginning, because you want this all epinucleus to be loose, so that when it comes off, at least you have a loosened epinuclear material. So once I take off this epinucleus sheet, as you can see here, so slowly and slowly I'm taking out this epinuclear sheet, and as this posterior plaque it comes off, you see that I can see that, yeah, so this is the last piece which is coming off. So you always need to maintain close anterior chamber, and once this comes off, I can see that there is a, of course, PCR which is there. So never withdraw your instruments out of anterior chamber, and don't let your chamber collapse. So whatever is there in front of your phaco probe, just take that and maintain closed chamber. Put OVD, viscoat if you have in hand, it's best. So maintain closed chamber. And when we see a posterior capsule like this gaping off, it means that of course vitreous is there. So now your strategy is to do anterior vitrectomy from anterior chamber and clear off the entire vitreous. So here I'm staining with tricot, and so your strategy is to clear off the vitreous before you do any uh, cortical matter irrigation aspiration. So I go ahead and put irrigation cannula through one side port and vitrector. So this is the cut IE mode. At this stage, we need to cut the vitreous first so that we don't cause any traction on the vitreous base. So without clearing this vitreous, you should never proceed uh, for doing cortical matter irrigation aspiration. And once you've done good, again maintaining closed chamber before I will take out my instrument. And after that, either you can use the same vitrector or you can use bimanual IA. So you can see because there is no vitreous there, I can easily strip off the entire cortical matter from anterior chamber nicely from one side. And again, before changing my hand, I'll put some OVD there. So we need to clear off. So at every stage, you need to maintain closed chamber. Again, I'm going and putting OVD there before changing my hand. And this is the last some fibers of cortical matter. I think this big defect which is there is easily visible now, which is through and through. So in these kind of cases where you can't convert this opening into a posterior capsular axis, the sizing of capsular axis is very crucial. So again, I'm maintaining chamber and before enlarging the incision. So I enlarge the incision to 2.83 millimeter, and this is a three-piece lens. So of course, these lenses are a little tricky to put, especially when you have a open posterior capsule. So it's very important that you take care of the leading haptic when it's coming out. So it's important that you always keep your leading haptic horizontal. So whatever direction your cartridge is, you should always try to rotate it so that this leading haptic always opens horizontal behind the pupillary margin. So I'm keeping it there horizontally. And after that, once the optics coming out, you rotate your hand in anti-clockwise direction. So in this way, your haptic will never go backwards into towards vitreous cavity. Again, go ahead and put some OVD in front of optic and put this IOL in sulcus. So once we put this lens in sulcus, if you don't have a capsular axis which is of appropriate size, you can't capture optic, and this capturing is very important for long-term stability of the IOL. So go ahead with Kugelens hook and put it behind anterior capsular axis margin on both the sides. So once you have captured it, you always go and check that yes. So once you capture both the edges near the haptic will become like a rugby ball, you know. And once again, you go ahead and do some anterior limited vitrectomy and put some myocol in anterior chamber and hydrostitch all the incisions. And this finishes the case. This is the post-operative photograph on next day. You can see that it's captured nicely, and it's this is the big posterior capsule defect which is there. Another case, same true posterior polar cataract. What I want to highlight here is once you take off this cortical matter and this posterior opacity, it comes off and you see a PCR there. So PCR doesn't always mean that there is a vitreous prolapse. So the fluidic currents in antechamber, they tell you, they guide you that yes, whether there is a vitreous is there or not. And secondly, as I said, the gaping of posterior capsule opening, it suggests you that yes, vitreous is there. So here I can see, so what I'm checking here is that the posterior capsule is not gaping and the fluidic currents are normal. So what I'm doing here is I'm to maintain closed chamber. I have a separate irrigation cannula. So before withdrawing my phaco probe, I'm putting that irrigation cannula attached to second BSS bottle, and then I'm withdrawing my phaco probe. So this is the another way you can maintain a closed chamber. And then my assistant is taking off the tubing from phaco probe, and I'm putting aspiration cannula through other side port. So you can see now here I didn't do any vitrectomy, but still cortical matter is nicely coming up because there is no vitreous. So PCR doesn't always mean that there is vitreous, but yes, you need to be careful that you maintain closed chamber, because if your chamber collapses, again putting second irrigation cannula through side port before withdrawing this, and you can see a posterior capsule opening there. And so these are the fibers, last cortical matter, which I'm taking out easily. And after that, you can see that how posterior capsule is, like a trampoline, it's dancing because there is no vitreous there. So now here I could see the edges of the posterior capsule tear. So again, I'm maintaining closed chamber, putting viscode there before withdrawing irrigation cannula, and I'm converting these irregular margins into posterior capsular axis. So wherever you can, when the PCR is small and you can see the margins of the tear on both the sides, you can convert it into a posterior capsular axis, and then you can safely place single piece IOL as planned in capsular bag. So here the leading haptic, it goes between anti and posterior capsule leaf, and you should not rotate the lens because of the torque forces again can cause. So I'm just pushing the haptic, bending it from the shoulder and putting it in the capsular bag. That way I'm avoiding the torque forces, and IOL goes nicely in capsular bag. Again put some Myocol and finish the case. So this is the post-operative slit lamp video. You can see that how nicely IOL is there in the capsular bag, and this is the posterior capsular axis which I've done. So, and IOL is nicely sitting in capsular bag. So I think with this I'll end my this presentation, and we can have some discussion before I go for second talk.
Excellent, Surgery Dr. Tart. I think, as
Thank
always,
you
I
so
think
much.
surgeries are just fantastic. I think you did manage these cases very well. Um, Important thing is that in the second case, particularly your chamber was very stable. In the
Yeah,
first patient, it was stable, but perhaps a little less stable. The second one was very stable AC, which is actually very important if you really want to keep the posterior capsule intact. Now, sometime when you have posterior polar cataract, there's a very fine membrane that there may not be a capsule, it may be a condensation of the vitreous, or maybe some, very fragile kind of a capsule. And if there's a lot of turbulence in the anterior chamber, that actually gives way. So I think you very nicely, you actually preserved that, till the end, and only towards the end you actually converted into the posterior axis. I think that's very nice. So what precautions basically you take to keep your things under control, because this surgery has to be very much under control. You have to be in control of each step. So what is your kind of
ठीक है।
your yeah,
कैसे बंद करेंगे?
how do you
5 मिनट
do
बाद बंद करेंगे। तुम लोग जाओ, हम एक दो लोग रुकेगा मेरे साथ के लिए।
I think some, yeah. So sir, as I said and showed also, that to maintain closed chamber is the key in these kind of cases, and also always to be gentle in all your maneuvers and try to delay the opening. In these kind of true posterior polar cataract, whatever you do in the end when you take off this opacity, is the it's slightly added to posterior capsule or it's already open. So it will come off. But if it comes off late, you have debulk almost, the endonucleus, cortical matter, and it's only the central base which is there. And moreover, PCR happening is not a problem. Problem is not to manage it well. So if you don't take off vitreous, if you don't cut the vitreous from antechamber, you try to pull out with irrigation aspiration or with phaco probe, you cause a lot of traction on vitreous base, which causes long-term implications and problems. So if you either go through limbal route and you follow the principle, I believe that whether you go from pars plana or from limbal route, both amount to same if you follow the principle of not causing traction on vitreous base. And of course, in post-operative period, it's important to do regular follow-ups and retinal examinations of these patients. It's very crucial. We should not forget. Especially we should tell to patient that yes, and of course in preoperative counseling also we tell everything that you may need uh, VR surgical intervention. All these things are there, and of course, post-operatively they come for monthly follow-up. You
do
should
you,
tell to patient because we may tend to forget that yes, we have to get Because after a few days, we also tend to forget that yes, this patient has this PCR or something, but patient will never forget that yes, I have to come for regular follow-ups.
Will you change your phaco parameters for posterior polar cataract as compared to the regular?
Yeah, so parameters are little on the lower side as compared to normal, like slow motion phaco. You should do like bottle height is little lower, and all parameters are little lower than normal.
Okay. And also, do you kind of pre-operatively do you try to look for the you know you know what is the
OCT.
probability or some way to tell that a particular case is more likely to end up in you know uh, posterior PCR and all posterior polar cataracts they don't actually end up in PCR.
Yeah, so those are I've found that the PPC which are small in size and like smaller than 2.5 millimeters, they are very small. Or if they have edges which has subcapsular opacities, those are not true posterior polar. So I feel that OCT, okay, you can do OCT. That will tell you that whether there is a pre-existing defect is there or not. But even if there is a slight doubt, if in many, we should tell our patient that there are chances. So if you don't see any defect on OCT, you can't tell patient that you won't have anything
I
because
believe that
yeah, because posterior capsule is thin even in those cases also.
Yes, Nitin.
may
That,
I want to include in the discussion. May I?
Yes, sure. Most
Yeah. So most of the time when PPC along with PSC is there, those PPCs are less likely to cause, I mean, there is a obvious dehiscence or PCR chances are less. Whenever PPC is associated with PSC, along with PSC and the kind of PPC picture is there, then the chances of true PPC is less. I would like to
So
have your
uh,
experience there.
yeah, you are right. So what happens is, so as I said, we need to stick to the principle, you know. If
Yeah.
even if it's PPC with PSC, we know in our heart we know, okay, we'll get away with this. But our strategy and
Okay.
principle should remain same, layer by
True.
layer separation, maintain closed chamber. So is the last when you are taking out the posterior polar opacity in the last, if it's a true posterior polar, I feel it opens up.
Give up. Yes. True.
Dr. Harshal, regarding the size, which
Sir,
size you prefer for this post-polar cataract?
which
The both,
size?
the parameters are lower side that you have already explained.
Yes.
But what type of phaco tip you are using? And for the big, basically, this what should be they use?
So I don't think size of phaco tip matters for in any of these cases. I routinely use 1.8 millimeter co-MICS tape, which I'm used to in all my cases. So, but phaco tip doesn't matter, I feel.
Uh, but if you want to have a very, very close, tight chamber, you should have the minimum bore phaco tip. I think that is more essential. Is the 2.8 or 2.6 incision size will might be little, it is a bit of surge or all.
Yeah. Yeah, so of course you should not have surge in your machine, even if your phaco tip is 2.2. I think most of the surgeons are nowadays using 2.2 or 2.4 only. That's what I believe.
The other thing at the end, when you are finding that the case is having dehiscence and you are at the end, and you said that you are putting viscode. So
Yeah.
I believe that sometime viscode, due to its consistency, may increase the the PPC, or it can increase the tear PCR.
No, no.
Most
If you have
likely,
a PCR, if you put Viscode, it acts like a
Lock
plug there.
maintain,
So
yes,
that,
plugging.
yeah.
But consistency of viscose is very high. Sometimes I've seen that some of the videos where I've seen, because once after putting that, once you enter with the fluidics, it causes jerk, and then there is, because of the consistency. So better is, I believe, that the orogel or something high molecular 1.5 or 1.4 or 1.8 consistency of hyprosol is also enough. When you are having very good PPC rexis, when you have made CCC in that way, because anyway the vitreous was not coming in your second case.
Yes, yes. So
Yeah.
that's why you should keep an eye on the PCR. If you feel that it's gaping, it means vitreous is there, and the fluid current it changes. The
Yes,
fluttering
sir.
of cortical matter and everything, it changes. They won't, move around with the fluid. Your posterior capsule edges, they won't flutter because there is a viscous vitreous which is there, which is, you know, preventing it.
Yeah. Very nicely
So,
done cases.
sir, good
I
evening.
think
Sir, one
we should
question,
Well
end
sir.
done,
here.
man.
Yes.
Excuse
Yes.
It is,
me. We should end
Sir,
up here because we have two more speakers and time is 7:30.
ma'am, I have
one
Yes.
one
question,
question.
ma'am. One question,
Ma'am,
ma'am. One question
sir,
from sir.
it is
Sir,
vertical chop or horizontal chop, which is better in this posterior polar cataract? Any
So
benefit?
So I think the vertical chop is always better because the trenching I feel gives put pressure on the capsular bag and on the posterior pole also. So if you
So,
do a phaco chop because you're holding with vacuum, the forces are always centripetal. You're always chopping and forces are always centrally placed. So that chop is always better, which puts less pressure on the capsular bag.
so
but, but
one question, sir. Sir,
Yes.
usually I've gone through some of the videos, and there is something shown like mechanical hydrodelineation. So can you share some experience? If like we are not doing the this one, so if you have any experience, can you give some insight to us?
So that is the mechanical delamination you want to say that many surgeons what they suggest is to not do cortical cleaving hydrodissection, but with the spatula they separate anterior capsule from the lens surface so that it becomes easier to rotate endonucleus. So
But that
that can be
happens only
done.
in softer cataract.
No, I'm just talking about, sir, separating endonucleus from epinucleus.
Yes.
Yeah.
So see if we have a softer kind of cataract. Then if
Okay.
you do hydrodelineation, it separates endonucleus from epinucleus.
Okay.
Yeah.
And sir, one last question. Do you have any
I,
experience like
Dr. Indranath,
hydroimplantation?
Dr. Indranath, please, Dr.
Yes, sir.
Indranath, we
Yes,
will take
ma'am.
up the questions in the last, and now we
Okay.
should over to Dr. Arup Bhaumik because it is 7:33. We have invited two more
Yes,
speakers.
sure, ma'am. Sure, ma'am.
So, Dr. Arup Bhaumik, please.
Yeah.
Good evening.
We have done your introduction.
Okay, yeah, I know. Can I am presenting my slide. Am I visible?
Yes.
Okay. So I just show one cases. One case of doing the subluxation slightly different way. I hope the Herschel Herschel will show the classical way. Here you can see this is a microspherophakia. The problem is the microspherophakia. Lens is very small. Whenever you try to fix the bag with whatever, the either Gore-Tex suture or Pauline suture, it will be the longer the length, but it is not able to because these equator of the lens never to reach in the sclera because there is a much gap in between the equator and the sclera. So there is a longer the length of the suture, then it will be the degradation of the suture is much more. So I am showing this slightly different technique here, which I am doing a few years. I am preparing for the pars plana vitrectomy also. For in this case, if required, you can see this. Now I am putting some viscoelastic, and you can see the how small the lens is. So if you try to fix the capsular bag with the sclera, then there is much gap in between. Then there will be longer strength. And if you tighten that, the lens will be slightly decentered. So my plan is to going to do a relatively smaller kind of rexis, so that 4.5 or 4.7, where I able to do sometimes is you need to do repeat the viscoelastic to stabilize the capsular antechamber. Now I am holding the capsular bag with the capsular hook, and this is a nucleus removal is not a very big issue because it's almost no nucleus, very softer cataract. So you can say I am removing all the nucleus and the cortex and the epinucleus with the with bimanual technique. Now I'm putting the CTR, and you can even show the after CTR implantation also maximum stretching of the capsular bag. The lens is so small. So now I'm planning the reverse way to fix the capsular bag. What I'm doing generally in the gross subluxation, we generally put the Ahmed segment or Sioni segment and fix it with the with the sclera, with the Prolin suture or the Gore-Tex suture. Here I am doing the supracapsular glue dowel and capture the optic so that lens will be secured and the lens will hold the capsular bag. I'm implanting this lens into the sulcus first, and sometimes this kind of it's slightly more maneuver, so it looks slightly messy. And this is a supracapsular glued interscleral fixation. I am just putting the forceps over the capsular bag, remove externalize of the one haptic from here, and I do the same thing I have repeated in the other side. Yes, you can see this, repeating the same thing. And now I'm capturing the optic with the capsular bag. I'm capturing the optic, and now this is called the supracapsular interscleral fixation of the uh, IOL. Now I am fixing, as usual, I'm fixing the Gabor-Shaded tunnel. I just putting the haptic into this tunnel and applying because today I'm not using any glue because glue is not absolutely necessary to fix the haptic. Yes. And this is the end of the surgery. Here, the lens is fixed with the sclera, and the bag was holding by lens is holding the capsular bag. Thank you so much.
Thank you, Dr. Bhumik. I think a very skilled procedure. But my question would be like, Dr. Harshal, how would you like to treat if it's a microspherophakia? Is there really any merit in preserving the capsule? Because at the end of the day, you are actually doing a sclerofixated IOL. So maybe you don't need the capsule there. Is there the advantage of keeping the capsule there? Because it takes a lot of effort and you need a lot of surgical skill, definitely.
Can I answer this?
Sure.
So there's a problem of interscleral fixation. The biggest problem is the spherophakia, pseudospherophakia. I have seen the lot of blue dial. There is a lot of pigment dispersion due to the phacodonesis of the lens. Phacodonesis then. This is the only technique. Yes, it is a difficult technique. You can go for the lensectomy and simple interscleral fixation or glue dial. But advantage of this technique is it reduces the scleral lens fluttering on pigment dispersion. This is the only advantage. And another advantage, I always anterior segment surgeon always try to prefer to keep the capsular bag as much as possible. That's yes. But yes, if you try to do the conventional way to fix the capsular bag, putting Sioni ring, Ahmed segment, I ultimately seen that over long run the lens is decentered because it's a very difficult to keep. Either you have to go lensectomy and go for the interscleral fixation, blue dial or scleral fixation, whatever. But if you want to keep the capsular bag, I think this is the way. This is supracapsular interscleral fixation is the only way to keep the capsular bag.
Keeping the skull bag would be like, is there any disadvantage of keeping the capsule bag? Because it will fibrose. There might be, phimosis of the or
I'm keeping the squirrel CTR in the capsular bag, and then I'm capturing the optic. So it is really, it is not, there is a, you just prevent the capsular fibrosis when you capture the optics and putting CTR in the. I did a 15, 16, 15, 16 cases so far in these cases.
excellent. Good.
I tried some normal cases also, subluxated, grossly subluxated case. It is if you want to fix the capsular bag, I need at least three Ahmed segment. Even then, the lens is absolutely thick and the lens is holding there, and there is no fibrosis. And the main problem of the probably is interscleral fixation or glue dial, whatever. There is a lot of phacodonesis. Even in if you try to do the accuracy of single piece, which is absolutely no for the scleral fixation. I think sensor multi-piece is the only way to do the glue dial of interscleral fixation. Even with the sensor single piece, multi-piece, there is a lot donesis in the lens.
I just want to add one thing if I'm allowed. I know I'm a retinal
Yeah,
surgeon,
welcome, madam.
but
Madam is the star discussant of our electrophysiology session.
so what I want to
Well,
say from this point of view is that, these advanced techniques, it is best left to experts like Arup. People should not go with the impression that these techniques should be tried out, done, because these are children many times, and we do see many children coming back with detachments because the vitreous was still hanging there, or there's been one IOL, two IOLs, three IOLs put in the eye. Some of them are in vitreous, some of them are in sulcus, and the Sioni ring, one haptic is caught in the vitreous and retina going back, and somewhere it is there, and even the SFIOLs. The sutures, they lose out after some time, and then after 5 to 10 years they come with subluxated lenses, and the glaucoma is always lurking behind in a lot of these eyes. And so if you have to do detachment surgery or glaucoma surgery or put a AGV shunt, these peripheral capsule and peripheral rings, your tube may be caught in that. I mean, Dr. Pandav is here, so we are seeing all these complicated cases. Yes, if somebody is an expert, they have spent their life like Arup or Dr. Jagat Ram, or people who are really doing these difficult cases and have enhanced their techniques. That is, should be left to them. People should not mess up such cases, because simpler things like, okay, do lensectomy, okay, they will need a phakic glasses or contact lens or something, but you are preventing a lot of things from happening. But newer techniques are there. It is good to get those techniques on board. So then people should practice those techniques. As Arup said, he's done 16 cases, 20 cases. You are meticulously looking at them critically, in a setting where you have facility for following up these babies. Otherwise, down the line, we lose whatever little we gain.
Yes, ma'am. It's a better. What I want to say, it is not rational. The put Sioni segment and fix the capsular bag in the sclera. Either you go for the lensectomy, plain lensectomy, followed by interscleral fixation IOL, but or you can try the suprascapsular this technique. But it is quite impossible. The small capsular bag, small lens to fix with the only Sioni segment or Ahmed segment into the
I
sclera.
totally agree. That's why I agree. I say that just leave them a phakic. As a
Mm.
retina surgeon, we love a
Yes.
phakic eyes. Do good lensectomy, leave them a phakic. If you are thinking of putting an IUL, then you really need to think what is going to be the long-term consequence of this. Really, should I put an SF-IUL or a iris fixated IUL or any other technique? Unless, we have enough proof or enough expertise of what type of IUL is good for these eyes, long-term outcomes. Because all the time we see, so many complications in these cases, which could have been just left a faking.
It's very difficult to put an IOL actually in these small bags.
Yes, that's what I'm saying. So, we really don't have enough data. And we hope, like Arup, he is doing these cases, he's collecting the data. It will be good. But that is at an expert level, it should be done. Not everybody trying to do that. Just leave them with.
Thank you, madam. Thank you for your expert opinion. You really enriched our running session also. So now over to Dr. Ayun Mohanta
So good
for
evening.
his presentation.
Good evening, Bharati Kashyap ma'am and Jharkhand Ophthalmic Society for giving me this opportunity. So I'll be presenting a case on IOL exchange. So I think my slide is visible.
No,
Yes.
I have to unshare. Sorry, I have to unshare.
No, it's okay. I think
No, it's there. It's visible. Yeah.
I have to unshare.
you have already stopped sharing, I think. Hello.
Oh yes, you're visible now.
Can you see my slides?
Yes. Yes,
So,
slide is visible now.
So this is a patient, a 58-year-old female with a bilateral implantation of a trifocal IOL, complaining of severe glare and halos with extreme capsular fibrosis and IOL disintegration after 3 months. I have planned to do a IOL exchange with a monofocal IOL. So this is how it goes. So as you can see, there is a gross fibrosis of the capsular bag leading to a huge disintegration of the IOL causing the photopic symptoms. So at the outset, it is very important to coat the endothelium with viscoat, a dispersive viscoelastic to protect the endothelium. And then as you can see, the capsular bag is absolutely fibrosed with the lens entangled in it. Very difficult to separate it from the capsular bag, moving the spatula from one side to the other, severing all the adhesions, then trying to lift it up from the bag. After multiple attempts, it's slightly loosened up. As you can see over here, one of the haptic was now coming out. And while I was doing this patient's husband, the doctor himself, was present in the OT. Just imagine the level of pressure I had. So almost all of the lens is now in the anterior chamber. After adequate injection of viscoelastics both on top and below the IOL in order to protect the endothelium as well as the capsular bag, I introduced a macule cutter which went like this all along the optic, and just one step and it was divided into two pieces, taking out one piece at a time, and the other piece was slightly bigger, so I had to do a hand over hand technique to take the other piece out. Again, I had to separate all the adhesions that were present inside the bag, the anterior and posterior capsular adhesions, followed by injection of a multi-piece IOL. The haptics of the IOL were placed on top of the capsular bag and did a optic capture, push the IOL optic inside the capsular bag. So aspirated all the viscoelastics that were there in the anterior chamber. Centered the IOL in position. The optic was then pushed inside the bag Once it is in, I trimmed the edge of the fibrotic capsular bag as much as possible so as to prevent further capsular phimosis. On both the sides. I had to cut it because I was not able to do a rhexis of the capsular edge. So then there was a nice adequate opening. And this ends the case. Thank you.
Yeah.
Thank you again. Very nicely done surgery. Excellent. I think sometimes we do get into this kind of a situation when you have to expand the lens here because you had a trifocal or multifocal lens, and there's the problem with the multifocal lenses that if you have a fibrosis, then they can be off center, and then patient get a lot of symptoms. I think mobilizing these lenses, from the capsular bag is very important when you are explanting them, and unless you are careful, that you can end up with a posterior capsule tear or and that can complicate your surgery. But I think you managed it very well. Now, I was wondering because because the capsule phimosis with the opening was small, maybe you could have enlarged it in the beginning only with a cutter or with a scissors, remove some of that fibrosis, and then you mobilize the or take out the.
Basically, I did not do it in the first place because I was not sure if I'm going to do a bigger size rhexis, I mean, a bigger size opening, which is not going to hold the lens in place. That will be a bigger problem because it's a square edge lens. So there will be a lot of iris shaping and pigment dispersion. So I had to first ensure that the lens goes inside the bag, and then I trimmed as much as necessary.
That's also good thing, actually. I think you managed it very well. Any question?
Dr. Ayan?
Yeah, Harshul.
Yeah. I think it was really wonderfully done, very meticulously done. Perfect. Uh, why didn't you place the haptics in bag? Like, why did you decide to do optic capture and put it in
Because
cell cast?
the bag was not, I mean, it was fused at certain points. And I was not sure whether if I put
But
the
the haptics of three Ps are very thin, no, as compared to you took out the single piece haptics which are thicker and which occupy a lot of space, and I'm sure it opened up the entire bag.
Yeah, that's okay. But
Yeah,
if there were places in which the anterior and posterior capsule were fused, which I was not able to dissect properly, if that
right,
is the case, then it's again going to push the lens to one side, the multipiece lens, if
right.
it's not adequately separated.
Yeah.
The bag, you are not even sure the 360 degree of the,
Yeah,
you're not
this
able
is
to
the degree,
separate.
yeah,
Yes.
separation of the bag.
Yeah. But do you have in this case, do you think that you do a posterior capsulotomy with the vitrector and capture more stable? But here we can see this it's stable, but the fibrosis is a continuous process. Some cases we have seen there's a fibrosis, even though it can continue in. Uh, so you can do the posterior capsulotomy with the vitrectomy cutter and capture the optic even more secured way so that it will be absolutely center.
Maybe, yeah.
Yeah,
So
okay.
I'd like to add one thing here. I'm Dr. Kashyap, sir. Sorry, came joined late. I'd like to add one thing that every time you are not very lucky to remove the whole lens, especially the single piece lenses, the fibrosis is so much that even a lot of trial, the one of the two haptics may not be able to be released. In such cases, we can cut that haptic and leave it as such.
Yeah. That we do.
Yes.
Because most of it happens with the Rayner model lenses, the
Renner model,
particular
yes.
batch of lens, Freedom lens, which opacified, and there are a lot of lenses which are there inside the bag, and the haptic and the anterior posterior capsule gets fused through it, and we have to leave the haptic behind, or else it's very difficult to remove it.
I guess this lens was extend from EdTech,
No,
if I
this
No,
could
is
make out.
Acriva.
No?
Acriva, the same design. Acriva.
Okay. Okay.
cyanometal optic
Okay.
lens, the Trinova lens.
It's a
Ah,
hydrophobic only?
and
Yeah,
it
hydrophilic.
hydrophilic. And I had a
Hydrophilic.
similar
So
patient
that's also
like
a
this. I have
difference,
to remove this lens. I'm waiting for that. Maybe I need to remove that these because these lens initiate some kind of fibrosis. So we
Hmm.
stop implanting this lens.
The
Yeah.
funny, the
So
funny part is the
hydropho
patient had the other, the similar
This is
lens in the eye
hydrophilic.
also, and she was about to, I mean, go for the explantation of that eye as well. I was planning to do it, but the patient didn't agree because whatever trifocality was there in that eye helped her for the near vision, which she had lost completely in the right eye, and she is very unhappy about the lost near vision, whatever it was in the right eye, which I had explanted.
So hydrophilic you can explant even 3, 4 months, but hydrophobic they are really difficult after 1.5, 2 months because the amount of fibrosis and adhesion which happens in hydrophobic platform, it's really many times difficult. And as Dr. Kashyap said, many times we need to amputate the haptic so that we don't cause any zonular dialysis in this case.
See, Harshul, the
Yeah.
hydrophilic lens, if it is a single haptic, there is a no problem. If it is a hole in the haptic, like
Yes.
Renner model, the
The lenses,
capsule
yes.
fuse in between, then it is impossible to remove sometimes. So
Hmm.
you have to cut the haptic and keep it is in the bag.
I think, sir, it depends on case to case. Even the
Yes.
single piece lenses, the the non-Rayner type, it will be very difficult. Sometimes it's difficult to remove it. So the easier way to is amputate it or cut that haptic, leave it as such. They remain inert. They doesn't create a lot of reaction. So it helps your capital is good, and you can put the implant the three-piece IOL.
Going to end this session here. And I'm really, really thankful to all the three speakers, Dr. Harshul Tak, Dr. Ayun Mahanta, Dr. Arup Bhaumik, all are stalwarts in their own
Harshul has
hospital.
another talk. Oh, Harshul completed two talks.
Actually, Abhi Rao,
No, no,
right
no,
now
no.
we are finishing
We'll do it
because
some
the
other
madam
time.
and
Yeah.
everybody has joined. We will
Okay.
take up next, and
Yes.
I from Jharkhand Ophthalmological Society, lot of entire Jharkhand has logged in, and we appeal from the society to everyone to vote for Harshul Tak. He's standing for a
Member
scientific committee
scientific.
member. So many are viewing on YouTube also.
Thank you
So
so much, ma'am.
thank you, Harshul. And
Thank you
you
for a
have been
wonderful
contributing
opportunity.
scientifically in our society. And
Thank you.
Pandav sir, immense magnitude of thanks to you because in such a short notice you have joined as a star discussant. And now over to the another session. Thank you all.
Harshul, congratulations.
Sir,
Ma'am, kindly appeal
Palace,
for me also.
congratulations to Harshul.
sir,
Yeah.
thank you.
And Panda sir, a special thanks to you also. And now we are moving to the another session. That is the master class in electrophysiology. And as a chairman scientific committee of the Jharkhand Ophthalmological Society, I welcome you all for this very, very advanced session on electrophysiology. We know that importance of electrophysiology, there's a lot of importance of electrophysiology in ophthalmology. It provides objective assessment of the visual function. It detects early retinal and optic nerve dysfunction. It localizes the pathology, whether it is in retina versus optic nerve versus visual pathway. It helps in prognosis and the patient counseling. It is very useful in pediatric, non-cooperative, and medico-legal cases. It monitors disease progression and treatment response. So one-liner, electrophysiology assesses visual function beyond clinical appearance. So with this, I welcome all the national speakers of the electrophysiology session, and over to Dr. Rahul Prasad to introduce the national speakers, and Dr. BP Kashyap to introduce our star discussant, Madam Subhadra Janai. Over to Dr. Rahul Prasad.
Thank you, ma'am. Thank you very much, ma'am.
Please share the
And
slides. We are
yes,
sharing
yes,
the slides.
sure, ma'am. So very good evening, and I hope my slides are visible right now.
Yes.
So yes, and very good evening. A very interesting topic of one of those topic that had been underrated, but now coming into a with a big bang. And as like ma'am just pointed out, a functional aspect of retina, a very valuable
Yeah, man.
topic. So now, coming to the introduction, it's my privilege to introduce the national discussant who are over here. To begin with, I would like to introduce Dr. Purna Chandra B. He is a vitreoretinal surgeon consultant at Narayan Netralaya. He had completed his post-graduation from the AFMC, followed by a vitreoretinal surgery fellowship from Narayan Netralaya, Bangalore. He has undergone additional training in inherited retinal disorders and electrophysiology from the prestigious Moorfield Eye, London. He has completed preparatorship on age-related eye diseases from Save Eye Sight Institute, Sydney. He has done a PhD scholar from Massachusetts University, Netherlands. He has presented several papers on national, on international forums, has published many articles in the peer-reviewed journals. His academic achievements are innumerous, which include Rima Mohan Award for the Best Paper in AIOS, Professor S. Natarajan Award for Best Paper in the Vitreoretinal Disease at AIOS, Professor Rohit Sethi Young Researchers Award, E.T. Selvan Award, AIS 2025, APOS Venegula Rao Award, which was for the Best Paper in Comprehensive Ophthalmology, Dr. E.S. Guru Prasad Best Paper Retina Award from Karnataka Ophthalmical Society, M.M. Joshi Overall Best Paper awarded by the QOS, J.M. Pava Best Paper Award that was awarded by the VRSI, Best of the IGO Awards, ASRS Honorable Mention 2024. He has also achieved GOCR Young Achievers Award. His area of interest include inherited retinal disease, electrophysiology, retinal vascular diseases, and gene therapy. Our second discussant is Dr. Praveen Sen. Ma'am is a senior consultant and a vitreoretinal surgeon from Agarwal Eye Hospital, Chandigarh. Our third discussant is Dr. Simar Ranjan Singh. He is an associate professor. He is a in vitreoretinal surgery department at the prestigious Advanced Eye Center, PG Institute of Medical Sciences and Research, Chandigarh. Then we have Dr. Swati Fuljile with us. She is an assistant professor from right now at Dr. R.P. Center for Ophthalmic Sciences, New Delhi. She has done her MBBS from Jawaharlal Nehru Memorial Medical College, Raipur. She has done her MD from R.P. Center, AIMS, New Delhi. Her professional experience include presently she is working as an assistant professor, senior research associate in neuro-ophthalmology and establishment services, again at RP Center. She is also a research officer at in the Eye Institute, Eye Disease of Cataract and Age-Related Macular Degeneration. And she was a senior resident again in neuro-ophthalmology and strabismus and glaucoma services. Her membership of professional bodies include World Society of Pediatric Ophthalmology and Strabismus, All India Ophthalmical Society, Delhi Ophthalmical Society, and the Strabismological Society of India Awards. Her accomplishments include winning of ANC Young Researchers Session in All India Ophthalmical Society annual meeting in 2008. She was an assistant editor in 2000 and 2008 for Strabiscope, newsletter of the Strabismology Society of India. She is also a reviewer of articles of national and international journal and has got many national and international publications. And then we have with us Dr. Tapas R. Pari, who is a vitreoretinal and pediatric retinal surgeon, is currently a vitreoretinal and pediatric retina specialist at Anand Bajaj Retina Institute, at Miriam Haiman Children Eye Care Center at LB Prasad Eye Institute, Bhubaneswar. He serves as the head of electrophysiology services across LBPI network. His area of focus include pediatric retina and ocular electrophysiology. He has almost 100 publications, 50 in pediatric retina in peer-reviewed journals, has served as a mentor for the ROP program in Nigeria and Bangladesh. He is appointed as the mentor for the ROP program in Orissa by the National Health Mission. His work on ROP has claimed many awards and recognition by the ARVO, World and Indian ROP, IROP Society, Vitro Retina and all AIOS, National Neurology Forum, and India. So from my side, now I would like to invite Dr. Kashyap to introduce our star discussant.
Can I have a slide, please? Dr. Bharti, can I have the slide, please?
Yes.
So I'll be talking about Dr. Subhadra Jalali. My friends, if you talk of retinopathy of prematurity, if you talk of complicated retinal diseases and the surgeries, the name is not complete if you don't take her name. One of the stalwarts, few of the stalwarts, if you count them, on the top notch, she's there. She is the network director, quality at LVPI, best known for her work in the area of retinopathy of prematurity. Nowadays, we popularly known as ROP. She is also the director of the Newborn Health Alliance, that is NEHA, at LVPI, and provides neonatal eye care. She is also on the National Task Force on ROP, Government of India, and is the expert advisor on ROP to a lot of countries like Bangladesh and Philippines. She specialized in managing advanced vitreoretinal conditions, ocular trauma and ophthalmitis, and primary genetic retinal degenerations. Dr. Subhadra has been associated with LVPI as a faculty. I have seen her working there very hard, learning, and then dispersing her knowledge to a lot of people. She had a lot of the medals and awards. She pursued a comprehensive fellowship, including 1 year in retina at LVPI. Later, she did a fellowship training at the National Eye Institute, Bethesda in US, in ocular genetic diseases, electrophysiology of vision, and ocular inflammation and uveitis. She also underwent a short-term fellowship program in the management of ROP and pediatric retinal disorder at the William Bluemont Hospital, Royal Oak, Michigan. Dr. Jalali has received several awards. She is still receiving a lot of awards. Her all the drawing rooms and all sitting areas are full of awards and memento. I don't know what will happen after some time. She has the Indian Neonatal Talent Research Award, American Academy Achievement Award, and Asia Pacific Academy of Ophthalmology Achievement Award, AIS Dr. P. Shiva Reddy International Award, IGO
I think we can
Platinum
stop
Award.
that.
Oh man, how it can be?
Sir,
We have to tell you.
everybody knows me. Let's move to the electrophysiology.
She has her career, over 750 presentations, 180 publications in national and international journals, and many chapters in books. Madam, you love exploring diverse cultures and cuisines as well, and also she enjoys reading and dancing and music. Madam, you are a multifaceted woman, and we welcome you, madam. You are a star person in real sense.
So with this, I want to introduce the discussants also on panel. So we have one young, energetic VR surgeon on board as discussant. He is Dr. Siddharth Madan. He's assistant professor ophthalmology, Guru Nanak Eye Center, Mansi. He's the medical officer in charge, pediatric lens clinic and nodal officer for ROP at GNEC. So welcome, Siddharth. And then there is Dr. Rahul Prasad. He's our joint secretary, Jhos, and looks after the retina department of Rio Rims Ranchi. The Vibhuti Bhushan, Dr. Vibhuti Bhushan, ex-secretary Jhos. They are all retina surgeons. Dr. Anshuman Sinha, the eminent retina surgeon, trained in LVPI. Dr. Vibhuti Kashyap, he has broken the world record by winning twin Red Buckler trophies at a time in 2025. He's an RPC trained VR surgeon. Dr. Vikramjit Pal, he's a senior retina consultant. Dr. Archana Kumari, she is also a senior retina consultant. Dr. Ritika, she is a senior retina consultant trained in Sankara Netralaya. Dr. Deepya Prabha is trained in LV Prasad. And Dr. Nilutpal is working as a retina surgeon in Tata Steel. So we have a lot of discussions on the board. And with this, we over to first to Dr. Purna Chandra for his presentation. Over to Dr. Purna.
So thank you so much, ma'am. And thank you so much, Dr. Prasad. We rarely get to, where people read the entire introductions while it was too much, but still it was good. So hope my slides are seen.
Yes, yes,
Hmm.
it's visible. It's
Okay.
visible.
Am I audible? Is my voice
Yes, you're
clear?
audible. Clear, clear.
Perfect, sir. Perfect. Thank you so much, sir. I know like it's an honor to present in front of, stalwarts like Subhadra ma'am, Parvin ma'am, and also BP Kashyap sir, who is the first person to start electrophysiology in Jharkhand. So, which I got to know a couple of years back. And thank you so much, sir. Today, I'll be covering the basic aspects of fulfilled ERG and few case examples. As we know, Parvin ma'am and Tapas sir will be covering the multifocal ERG and pattern ERG and other things. So to start with, fulfilled ERG is nothing but it's a mass response of the retina to a luminous stimulus. So whenever you stimulate the retina with the light, so that is for the fulfilled ERG, there will be biochemical and ionic changes in photoreceptor and RPE, which generates electrical potential, which is recorded as electroretinogram. So we have different waveforms in fulfilled ERG. Whatever I'm talking, it will be about fulfilled ERG. The first wave is a negative deflection, which is called the A wave, and it is from the outer retina, so that is photoreceptors. B wave is the first positive deflection. It is predominantly from the bipolar cells with some contribution from the molar cells. And you can see some deflection along the ascending limb of the B wave. These are called oscillatory potential, and these are from amacrine cells. When it comes to ERG, there are different forms of ERG because whenever we advise an ERG, we need to know what kind of ERG we should advise and what is the indication. Fulfilled ERG basically represents the functional integrity of the entire retina. Pattern ERG is predominantly from the posterior pole. In multifocal ERG, we check each and every point on the retina. That's in very brief. I'm sure Parvin ma'am and Professor will cover these things in detail. So this is how a typical fulfilled ERG printout looks like. It will have a dark adapted responses and a light adapted responses. So the dark adapted responses are recorded after 20 minutes of dark adaptation. 20 minutes means it has to be absolutely pitch dark. During these 20 minutes, if there is an exposure to light, it's better to repeat the 20 minutes. In this dark adapted state, if you stimulate the retina with the lowest intensity of light, that is 0.01 candela per centimeter square, what you get is a predominantly rod driven response. And once you increase, there is no A wave here. It's only represent the rod activity is represented by the bipolar cells. So you see only the B wave because at such a low intensity stimulus, the depolarization of rods is not very easy to record. That's why A wave is not seen here. And once you increase the stimulus strength to 3 candela per centimeter square, the A wave starts appearing and what we call it as a combined response. And you can increase the intensity up to 10 to get maximal combined response. This is followed by a light adapted response, which is after 10 minutes of light adaptation. So, which has a single waveform. So, which is predominantly cone driven response. In the same light adapted state, if you stimulate the retina with 30 hertz flickering light, rods cannot respond at all to such an high flickering light. What you get is an isolated cone driven response. So we started with an isolated rod driven response and we ended with a cone response with a spectrum in between. So whenever we look at the ERG, we need to look whether the rod component is affected, or cone component is affected, or both are affected, or is there any special waveforms, which I'll explain with the case example. So now I'll go through a few case examples. More than cases, these are stories of different individuals who came to us after consulting multiple places. So this is one such story of an young gentleman. So had an eye pain, eye strain, burning sensation, light sensitivity, and photophobia since 2008. And he was diagnosed as mild dry eye, and early keratoconus, and started on multiple lubricants. Literally visited every eye hospital in the country, and the symptoms persisted, developed, work life stress, altered sleep cycle, and then he changed the workplaces, switched jobs multiple times because whenever he went to his working place, because his colleagues wanted more light, whether he was very allergic to light, he developed a lot of, because of which he had to change job multiple times. Then he had consulted psychiatrist, and he started him on amitriptyline and also propranolol for anxiety. It was a known case of hypothyroidism and also hyperlipidemia. And obviously, because of all these stresses, he became alcoholic and a smoker, which is not good. So he basically was referred to me from the refractive department because the Rohit told me absolutely there is no keratoconus at all. There is nothing to do with the dry eyes. And when the Rohit tells there is no keratoconus, means definitely there is no keratoconus. So I thought, just look if there's something wrong in the retina. So this was his profile, best corrected vision. His vision is fine, perfectly fine. He's 6'6" and 6. Color vision is also completely normal. Anterior segment is fine. So only problem is he cannot tolerate the light. So this was his fundus photo. I know in Optos it's not made out well. For me, in clinically, when I saw the right eye foveal, though the fundus appeared normal, foveal reflex was slightly different compared to the left eye. It's a pseudo color image. I don't think you people can appreciate that. So this is the white field fundus autofluorescence, which was normal, and this was the OCT. This OCT, if you see the ellipsoid zone in the subfoveal region, I felt it's slightly thinned out compared to the other eye. If someone claims that could be normal, I don't have any problem. I take it as normal. For me, it looked definitely a little different compared to the other eye or compared to any normal patients. So to complete the workup, I did OCT angio because this patient was very keen on getting everything done. OCT angio, the both superficial and deep capillary plexus was normal, and his fields were also normal. Okay, then we subjected him for the ERG. If you look at the ERG, so the bottom row represents the normal, and this is his right and left eye ERGs. So the dark adapted responses are completely okay. But if you look at the light adapted responses, there is a 50% reduction in the amplitude compared to the normal. So that means there is some cone dysfunction in this patient. That means whatever he's been telling for all these years, it's not a lie. That means whatever he's experiencing, it's not a neurotic symptom. There is an actual, again, some problems with the cones which are not able to handle the light. So then we did a multifocal ERG. So definitely there is a reduction in central responses, and all of us who do ERG, we know the light peak should have been little taller and the P1 ring ratio should have been higher. So definitely little less. Left eye was little better compared to the right eye. And this was the pattern ERG. As compared to the normal right eye, there was a gross reduction in P50 amplitude, and 95 was little better. And the left eye was almost near normal, maybe a mild reduction in P50 amplitude. So if you put everything together, fits well. Right eye, I suspected some ellipsoid zone, and in the same eye, the pattern ERG and multifocal ERG response are also less. Left eye also there is a functional deficit, though it's appearing structurally normal. So this is one patient, where we didn't treat at all. We just told them that there is an explanation for whatever the symptoms you are experiencing, and he was so happy. Just imagine just roaming around with, just hunting for what's wrong with, and everybody thought he has psychiatric symptoms and all that. I just gave a photochromatic glasses and I gave a letter to his workplace that this person has light sensitivity because of cone dysfunction in retina, the reason for which we don't know. So better to, he should work in a place where the lights are not very bright. So that made a huge change for him. And I've been following up this patient for almost 2 years. He's off all the, alcohol, smoking and all that. He's doing really well. So this is, as a doctor, you need not always treat. Just giving an explanation to what they are going through might make huge difference. I suspected, it could be an occult macular dystrophy or could be a variant of bone dysfunction syndrome and all that. We subjected him for genetic testing. It could not, pick up any of the mutation, but still, you never know. He may be carrying some mutation which may not have been reported yet, or some and it could be the cone dysfunction, could be post-inflammatory sequel, it could be anything, but at least the patient has an explanation for that now. And the root cause, we'll follow up and we'll see what it turns out to be. Maybe repeat genetic testing after a couple of years. That is the story of the first case. The second case is a 17-year-old female, main complaint of deviation of eye and shaky eyes with photophobia noticed since birth, using glasses regularly and high frequency, low amplitude pendular nystagmus, which choose to dampen on convergence. So this was her best corrected visual acuity and the corresponding refraction. She was improving up to 660 in the right eye, 6 by 48 in the left eye, and this was corresponding reduced Snellen's for a near vision. If you look at her color vision, it was grossly abnormal. So she was not able to identify any of the plates and Shearer's charts. I think I know Subhadra ma'am and Praveen ma'am, they already know the diagnosis now. So misdiagnosed with this kind of this thing. That is also what I suspected. So fundus clinically looked normal. OCT again was absolutely normal. Autofluorescence, maybe I say there is subtle change in the fovea, but if somebody tells normal, that's okay. It can be normal. So posterior pole autofluorescence, which looked suspicious on the wide field outdoors, in the spectralis, it looked okay. It appeared normal. But look at the ERG. There was a surprise here. As compared to the normal, the dark adapted responses are grossly reduced. And if you look at the combined response, the A wave is forming, the B wave is not even reaching the baseline. It's getting terminated here itself. There is an electronegative waveform here. And light adapted responses are grossly reduced or undetectable, as we see in a case of achromatopsia. If we just look at the light adapted responses and the patient's symptom profile, it perfectly fits in case of achromatopsia. But this electronegative ERG is something which was surprising to me. So maybe, and it's quite stationary, and the patient is very clear, and she cannot face, bright lights, and in dark also she's uncomfortable. It's a very rare combination of CSNB like changes and an achromatopsia. I saw this patient recently, and she's yet to undergo genetic testing and all. It will be interesting to see what mutation, what gene is involved, which can cause both the component. Fine. I'll just show a couple of slides on dystrophinopathy because this is the most common second opinion I get, not only from retina colleagues, even from the UVR department. So the Frederick Best was the one who described this for the first time. The pathophysiology basically revolves around the dystrophin gene, which is expressed in the basolateral membrane of RPE. Basically, it plays a role as calcium activated chloride channel, and its role in normal ocular development is also being proposed. So I'll just show the 3-4 families. This was a 11-year-old male born out of consanguineous marriage. So I had a vitaliform like deposit on the fundus, which was more prominent when we did an autofluorescence test. And OCT showed subretinal fluid and corresponding deposits you can see over the RPE. The full field ERG was completely normal. But if you look at the EOG, the light peak, which was supposed to be present here, which was not there. A normal ERG and a abnormal EOG with the clinical feature, whatever I showed, it fits into an autosomal dominant breast. But I'll come to that later. So this was the second family. Proband was a 25-year-old male. If you look at this as compared to the first patient, the vitaliform deposits were quite extensive. If you look at the OCT, in addition to subretinal fluid, there was also an intraretinal fluid. Both ERG and EOG was abnormal. In fact, EOG was almost undetected. It's a flat line. So these are the cases which commonly, get misdiagnosed for the posterior uveitis. Most of the time they reach me, they'll be on all kinds of immunosuppressant. They would have received injections and for pachychora spectrum and all that. So that case was a 21-year-old female. The proband was 21-year-old. She had multiple other affected family members, and parents had history of consanguineous marriage. And this is the complete family. The proband's vitaliform deposits were somewhere between the first and the second case. This is the proband. This is the sibling, first sibling, second sibling, and the third sibling. If the OCT, the fluid was predominantly subretinal, minimal intraretinal component. So what's happening with all these cases? why so differently they are presenting. The gene involved is the bestrophin. The first one is a dominant best because there was an heterozygous mutation in the bestrophin gene. So the second two are recessive best, that is mutation in both the gene. But the difference here is one is homozygous mutation in bestrophin gene, which is of a little severe variety. The other one is a compound heterozygous mutation in bestrophin gene. So this is the beauty of IRD. Sometimes it could be the same gene depending on inheritance pattern, the mutation, the manifestations could be different, which we published long back. So I'd like to conclude with this particular slide. If you just look at the OCT, this all looks like, spectrum of the same disease, maybe a pachychloride spectrum. But let me tell you, the first case when we stimulated them with the long and medium wavelength cone, it was undetectable. When we did the other way, there was an exaggerated response. This is a case of enhanced S-cone syndrome, and it had a mutation in NR2E gene. So the second one is a case of juvenile retinoschisis. You can see a classic electronegative B wave and they had a mutation in RS1 gene. So third is which I already showed. It's a case of recessive bed due to homozygous mutation in BEST1 gene. So this is what I always remember and I would like to convey. This is what I learned from my mentor, Professor Graham Holder, when I was at Moorfields. Do not fit electrophysiology into clinical diagnosis, fit clinical diagnosis into electrophysiology. Thank you so much.
So it was an excellent talk, and of course, I would like to invite any questions. Any questions are there?
Not a question, but I wanted to just comment. Thank
Yes,
you,
ma'am.
Puran
Yes,
Chandar, for an excellent presentation. I think what you rightly showed was that electrophysiology is the functional test, and all the others are sort of the structural tests. And we need to have combined information of both because there's so much overlapping features, structure and function, and for us to come to a definitive diagnosis. Previously, all these diseases would just be lumped into retinal dystrophy. There's no treatment. Just go to a blind school, or you're going to lose vision. But what we have learned over the years is many of these diseases are actually slow growing, or they are not even dystrophies, or they have various, prognosis. So today the patients want to know exact answers. They want to know how it is. They have so many questions. It just cannot be brushed aside. So a multimodal imaging, which includes electrophysiology and a proper workup of the patient right from history. I always insist that history is the most important thing. You may have all sorts of tests and AI and whatever, but it will never replace the history. If you don't spend time asking history, then you can do all sorts of tests in the best hospitals and best doctors. You will always falter. So I also, like Puran Chandra said, spend a lot of time on history. Ask the patient, what is exactly your problem? What is happening? Don't write like blurred vision. So usually we write poor vision, redness, watering, pain. This is common. Irritation, no. Ask that specific question कि आपको क्या प्रॉब्लम होता है, कहाँ पर प्रॉब्लम होता है, आपको देखने में किस चीज को देखने में दिक्कत है. So if you ask these very direct questions, patient will tell their story. Then it just narrows down. You know exactly what that patient has, even if you don't have advanced testing techniques. So of course then all the other things will add up. You can do OCT angio, electrophysiology, but don't miss out on the history. I think that very nicely, Puran, you have shown. And always look at the whole picture of the structural test, functional test, patient's complaint, and all the tests and whatever we do should be directed to mitigating the suffering of the patient, to healing the patient. It should not be just for the academic purpose. These are not for academic purpose. Of course, we learn, we do research, we collect all the data. But ultimately, at the end of the tests, the counseling of the patient and explaining to them each and every test which has been done and what it is adding to his information, that really gives the sleep and the healing back to the patient.
Yes, ma'am. Very rightly said, ma'am. Very rightly said, ma'am.
I'm getting more, especially the history part, what you told, and also the diagnosis. The patients now, there is no treatment. That's okay. They accept it. They want to know what's the prognosis. what's going to happen, what kind of career they should choose, and what they want is better, and how to prevent transmission to the next generation. So all that definitely there, it's our duty, as a doctor, as I was telling in that case, it's not always doing surgery, giving injection, doing laser. Of course, it's good. Sometimes you may not do these things, but spending time with patient, giving them the right advice makes huge difference, because I have many patients who are RP or cab drivers. They don't know. I mean, unless we educate them and all, it's a social responsibility, not just. And sometimes it's history, as ma'am rightly said, not only they may come for the eye, we have picked up many life-threatening diseases because of the ERG, malabsorption, intestine lipofuscinosis, cirrhosis of liver, and many other things like autoimmune retinopathy, carcinomas retinopathy. It's like what ma'am told makes, it's really, I mean, as I said, can't agree more on.
True. True. So we move on to our next talk, which will be by Dr. Praveen Sen, and she will be talking about multifocal ERG and pattern ERG. Ma'am, are you there? Hello?
Yeah.
She's very much there.
Yes, ma'am. Can you please start your slides, ma'am? Can you please
Sure,
share
I'll
your
do that.
slides, ma'am?
Thank you, Dr. Bharti and Dr. Kashyap for having me here. And it's always a pleasure to talk about electrophysiology. And here I am. And I think Dr. Purna's talk was very enlightening and very interesting. So from there, I would move on to another aspect of electrophysiology, which is multifocal ERG. He spoke to us on the full field ERG, which gives you a mass response. But then we know there are a lot of conditions in the retina which may not affect the global retina and which may affect the central area, the heredomacular degenerations, and the macular dystrophies. So here we need something which can elicit the function of the macular area. So that is the need for multifocal ERG, that it records many focal responses simultaneously from the posterior pole of the retina. So just to put things into perspective, where full field ERG tests both the function of the rods and cones, multifocal ERG is largely cone driven because it is tested under photopic conditions. And where full field ERG is a global response, multifocal ERG is simultaneous measurements of multiple retinal responses at different locations at the macula, and it maps about 40 to 50 degrees of the macula. So full field ERG is actually a true electrical response, but multifocal ERG is a mathematical extraction. So this is basically the setup for a multifocal ERG. You have a stimulus which is very different from the flash stimulus that you see in full field ERG, and it is done with ideally an electrode, which is a stable configuration, and a bipolar electrode. And this is how the response looks like. It is given in three forms: in form of focal responses, a topographical response, or in a form of a ring densities. So the fixation is very important because then only we will know, we'll be correctly focusing where is the fovea and where is the parafovea. And this should be monitored throughout the procedure. And eyes should be subjected to multifocal ERG with refractive error correction in place. And this is what the stimulus looks like. It is cone driven, stimulates the central 40 to 50 degree, and these hexagons are moving in a pseudo-random kind of sequence. And you could have a test of about 37 responses or 61 responses or 103 or 241. So you may think that, oh, 241 is great, so I must do this because it is testing so many areas. But the thing to remember is that the 61 element test, the duration of the recording is less, but for 103 or 241, the duration which will be much longer, and the signal will be small, so the low signal to noise ratio, plus the patient may get tired because of the longer test procedure. So these are the averaged ring densities which are also given, and this is very useful in you getting to know the topography of disease, whether it is involving the fovea, parafovea, or the region around the equator, and this is used in diagnosis as well. So this is very useful in getting you the topography of the disease. But we must remember that topography maps are good to look at, but they should not be seen in isolation, and you must look at the waveforms as well. So this is a typical waveform of a multifocal ERG, almost similar to that of a full field ERG, where this is the component which is got an origin of almost like the A wave, and this is simulates the B wave of a full field ERG, and these are the kernel responses. This is mathematical extraction which is done by the computer itself, and these responses are given. And when you do the interpretation, you same just like you look at the A wave amplitudes and the implicit times, here also you look for the N1 and N1 P1 amplitudes, and largely we look at the amplitudes, but we could look at the implicit time or the delay time also. And as an algorithm, we must remember whether we are doing full field ERG or multifocal ERG. Amplitude reduction usually means that the number of functioning cell is reduced, or there is cell death, and a delay or a peak time delay usually signifies that the number is okay, but the cells are sick or dysfunctional. So these are some of the examples of how a topography would look like. We can obviously see that the periphery here, the responses are good, but the central area, the responses are not so good. So this is a central retinal dysfunction. This is a peripheral retinal dysfunction. Central area is more preserved. This is a generalized reduction, and this one is probably localized to this part and maybe something like a BRVO or BRAO. And it is important to know the artifacts when you're interpreting. This is a very good multifocal ERG, but look at this. You may think that these are good responses, but actually this is nothing but noise. It's almost similar to the electrical noise that you will get even when electrodes are not connected. And this is eccentric fixation, or the patient has moved his eye. And so some few clinical applications or scenarios, and you can see this if you look at the retina here on both sides. These are the fundus pictures of two different individuals. They almost look similar, but if you see, it's these the full field ERG almost looks normal for both the cases, but if you look at the multifocal ERG, this is nearly extinguished, and this shows that the response is poor only in the central area, and the peripheral area is well preserved. So this actually is Stargardt's disease and affecting only the central retina, whereas this is a cone rod dystrophy, and the having a bullseye maculopathy, so that even though functionally anatomically only the central area looks poor, but functionally actually in the early stages you may have central involvement first, and the amplitudes may slowly get reduced on full field ERG as well later on. So here is another example. When you look at a case of retinitis pigmentosa, everything looks extinguished, but when more and more of these cases, suppose, go in for gene therapy, how would you monitor? So this is how you monitor. You can see multifocal ERG, which shows that in yes, one or two waves in the center, the records are still present. And so, as I said, now multifocal ERG has once again come into the foray, because in the gene therapy trials, this is one of the way to assess the response to gene therapy, along with, of course, other functional endpoints which are now developed. So again, as I said, other macular dystrophies like the occult macular dystrophy, or this is the only thing which may be abnormal, and the role of multifocal ERG in drugs toxicity is well known, and various drugs can cause retinal toxicity, especially more so to the macula, and multifocal ERG can pick it up. Hydroxychloroquine toxicity, it is absolutely essential. We have lots of our patients in the clinic who are on HCQ, and they come for routine toxicity analysis, and we all know that multifocal ERG may get affected even before you see changes on full field ERG or you see changes on OCT. And that is why multifocal ERG is one of the screening criteria which has been put forward by AO for looking at the toxicity of hydroxychloroquine. And any patient who has been on HCQ for more than 5 milligram per kg body weight, and for more than 5 years must have it. And those who have subnormal kidney function or tamoxifen use can start having it earlier. And sometimes in my clinic, when patients do come in with you history of HCQ use, I like to have a baseline test done so that you would be able to better monitor the progression of disease. So these are some other examples where other drugs causing macular toxicity can be monitored. In fact, the role of multifocal ERG has now even been used in a lot of research on diabetic retinopathy, because even before the diabetic retinopathy sets in, multifocal ERG may be abnormal. Here you can see even the localized areas of hard exudates and all can have reduced multifocal ERG. And this is a normal subject, and this is a diabetic patient without DR. And you can see already the multifocal responses are low. And in patients with early DR or late DR, they may be extinguished. Even in patients who have diabetic macular edema, the delay in multifocal ERG is far more significant as compared to a patient who has same kind of NPDR but without diabetic macular edema. So just a few things to remember. A caveat is that do not use multifocal ERG in isolation. You must do it with fulfilled ERG at least on the first time. Even if it's an HCQ toxicity, you look for a fulfilled ERG first. Document that it is normal before going on to do a multifocal ERG to say that this is macular toxicity. Just a few slides on pattern ERG as well. It plays a critical role, and because it gives you a combination of macular function as well as the ganglion cell function. And this is the detailed electrodes which are used to record pattern ERG, and it has got these two essential components. The P50 amplitude is the one which is more representative of the macular disease, and N95 component, which is more representative of the optic nerve function. So just to give you an example, if you see that here this is a combination of a normal ERG and an abnormal PERG, means that there is a decrease in P50 component here as compared to this. So this is a macular dysfunction. But if you have an abnormal ERG and an abnormal PERG both, then this means it is a generalized retinal dysfunction. So here you may see that the pattern, before you really start interpreting, you see that the pattern ERG is much more reduced. But sometimes even something like a simple case of macular edema itself may cause it, because large amount of fibers from the macula are going into the optic nerve decussation. How to distinguish between an optic nerve dysfunction and macular dysfunction. So if you have a P50 amplitude which is normal, then it's more likely to be an optic nerve disease. Abnormal P50 amplitude means macular disease, and N95 is decreased, then it's an optic nerve disease. N95 is usually unaffected in macular disease. Macular diseases can even have extinguished pattern ERG, because where the vision may become so low that pattern ERG will be unrecordable. Extinguished pattern ERG is usually not seen in a optic nerve dysfunction. That's all about pattern ERG and multifocal ERG. Thank you so much.
Thank you, ma'am. I'd like invite if there are any questions to ma'am, although she explained in a great detail and in a very simplified way, ma'am.
So I wanted to ask Praveen that, we have now these two tests for macular function, both pattern ERG and multifocal ERG. Is there a preference of doing one over the other in a certain patient, or, both are doable? Because some machines may not have one or the other. So how should people go about doing the macular function? Should they select pattern ERG or multifocal ERG? And are they giving the same information, or how do we, use these two tests?
So actually speaking, pattern ERG is something which is recommended by most of the people, that it should be done in all cases, because it is actually showing you the central, not only the macular function, but also the optic nerve function. Now, if you compare pattern ERG, which also shows you the macular function, as compared to multifocal ERG. But if you want to know the distribution of disease, whether the like HCQ, we know that perifovea may get involved first. Then if you want to know the distribution, that yes, it is the foveal involvement or the perifoveal involvement, because that also helps you in making a diagnosis. So if you want to know that kind of distribution of disease, then you look at a multifocal ERG. So in cases where, and then pattern ERG will still probably look at some amount of rod or cone function, but that is again, both are done in they are cone driven largely because they are done in photopic conditions. So I would say that when you are looking at pattern of disease, you are looking at multifocal ERG. When you're looking at more of whether it is optic nerve or it is a maculopathy along with a full field ERG, a pattern ERG can give you a better response. Most of the conditions, most of the machines will be able to do a pattern ERG as well as full field ERG. For multifocal ERG, you will need a separate stimulus and everything, which is a separate investment. So if you want to cut the cost of your equipment, probably it is multifocal ERG which has to be bought separately, but pattern ERG and full field ERG can be done together.
So it would boil down to what is the question that we are answering, as you rightly said. If it is an early HCQ toxicity, the pattern ERG may still be normal because it is a mass response from the whole of macula, although it does show. But if it is like a macular dystrophy, which we are looking for, then it will be abnormal because, at least 50% of retina is involved. But you rightly said that, the flash ERG alone will not tell us anything about the visual acuity or the central, affection, which is what many patients will have, a reduced vision. So it should not be used. Flash ERG can tell you about the disease in the retina, but it doesn't correlate with the vision. The pattern ERG, if it is abnormal, will tell you something is wrong, but if it is normal, it could still have some area of that macula affected, like you said, the perifoveal area in HCQ, which will be missed by pattern ERG. So all these are complementary. I think people who use these tests should know exactly what each test is testing. Like, we do B scan or CT scan or MRI. Then we know, okay, what things one picks up versus the other. So same thing for electrophysiology. We should know what does it pick up. If it picks up that, okay. But if it doesn't pick up, then we have to think of the alternative. Yeah, Dr. Kashyap, you wanted to ask something.
I want to add something that all the electrophysiological tests, they take a lot of time. If somebody has thrown light on the patient's eyes and he has the dark adaptation is elongated for a long time, and and this is a costly affair. It takes a lot of time. So what I do is, if there is any suspicion of a patient of having a glaucoma, so this patent ERG helps you a lot. It helps you a lot, and otherwise, other diagnosis, you confirm the negativity of the disease that okay, you have this problem, you not get the vision. But then there are other things like the opaque media, the opacity or the vitreous hemorrhage. Now it really tells you that okay, the patient can have vision. You can give the patient good news that well, you're likely to get vision.
Yeah, so optic nerve dysfunction is something which is picked up very well with the pattern ERG, but multifocal ERG will be quiet about it. So this is another thing, that is why in glaucoma, in optic neuritis, you would want to do definitely a pattern ERG as well.
In some cases, madam, if the macula is very badly injured or is very badly affected, subsequently, you get a bad the the ganglion cell.
Yes, the whole pattern ERG will get extinguished if there is a bad macula. So that is what, if you get an extinguished pattern ERG, you are more likely dealing with the maculopathy than you are dealing with the optic nerve disease. Usually, exception to it is probably very acute onset optic neuritis, where we know that the vision can suddenly drop down to counting finger or PL plus. Those cases, you will have pattern ERG also, which will get extinguished. But otherwise, most of the times, optic nerve disease, the pattern ARG will still have some response. But in a very severe maculopathy where vision is very low, pattern ARG, because these are very low amplitude waves, so they very quickly get extinguished with a poor visual acuity.
Yeah.
Yeah, Dr. Divya, you have raised your hand. Would you like to ask something?
Yeah, very enlightening talk, ma'am. So I wanted to ask one thing. So in cases of HCQ toxicity, if a patient is showing HCQ toxicity in multifocal ERG, we stop the HCQ. Does it get normal once we stop the HCQ? Or if it becomes normal, can we restart the drug at lower dose?
Actually speaking, the HCQ toxicity is known to be irreversible. So whatever damage has been done, usually it will not come back. But yes, we at least may prevent further damage. That also, most of these drug toxicity, once you stop the drug, the damage may not stop altogether. Still, it may progress to some extent, which is why early screening and detection is very important in these cases and should be emphasized.
Okay.
I had one point on the HCQ since it's common one. AO recommends screening after 5 years. So
5 years,
just
yeah.
because multifocal ERG is abnormal, you don't stop. You do multifocal autofluorescence 10-2 OCT. If any two of them are abnormal, then also I will not stop because in Indian patient they don't go to a severity of losing maculopathy and all that. I discuss with rheumatologist how it is important for to take HCQ. Sometimes I considering reducing the dosage. It's like they are taking 400 mg, I'll make it
200,
200 mg.
200
They're
mg, yes.
taking 200 mg PD, I'll make it OD 100 mg. It's like tapering because some patients are so dependent on this HCQ. Their rheumatological symptoms are so normal with HCQ. The moment you stop, you may this thing, but that is what I do it. Of course,
No,
if it's a very
again,
obvious bullseye maculopathy and all that, you have to stop it. But very early subtle, where structurally normal, only multifocal and 10-2 are showing changes, you can still discuss with rheumatologist.
plus the thing is that the alternative medication for rheumatoid arthritis are even more toxic, na? If
More
you
toxic.
Exactly. So it's that has to be subjective. You
to
cannot have a
make a thin line and always go back to the rheumatologist and then discuss and do things. But that is advantage if you detect it early, you can most of the patients are taking much more than which is actually required. So you can easily bring down the dose.
exactly.
Thank you, ma'am.
Thank
Thank
you.
you very much,
Thank you.
ma'am. Excellent discussion. Now, I would like to call Dr. Simir Ranjan Singh, and he will be giving a talk on when an ERG is all you need. Sir, would you please start your slides?
Thank you. Thank you so much, sir. I hope my
Yes, it's visible, sir. It's visible.
slides are visible.
Yes, sir, it's visible.
Thank you so much, and thanks to Jharkhand Ophthalmological Society, Dr. Bharti Kashyap, for the kind opportunity. So we saw a very lightning talk by Dr. Purna where he described full field ERG, and we had a discussion about multimodal imaging and how that kind of helps you imaging functional as well as structural to give you a diagnosis. So I'm going to show a couple of cases here where electrophysiology or a full field ERG is all that you need to make a diagnosis. Not to say that you don't want to do the other tests, but in this, it is something in which the full field ERG itself is pathogenomic and can give you a genetic diagnosis right from there. So this is the first case. I'll be showing two cases. This was a 16-year-old male who presented with parents had noticed diminution of vision at 6 years of age when he started going to school. And that is the time they got the child to us. They said the child is holding books very near to face, difficulty in reading, some hemarlopia, but no nyctalopia at that point of time. Uh, he was seen in the pediatric ophthalmology service, but the fundus looked absolutely normal, as it does in a lot of these dystrophies, especially in children. So it was just prescribed spectacles. The vision was just counting finger 3 meters, 6 by 60, and then lost to follow up. Presented back to us a couple of years ago when we were more well versed with what dystrophies are, what genetics is, and what electrophysiology is. So it was a born out of a single child born out of a non-consanguineous marriage. The right eye had a best corrected visual acuity of counting finger 2 meters, not improving, and left eye 6 by 60 had a esotropia of 15 degrees. Posterior segment I'll be showing in the photographs. Color vision, the child was able to read only the demo plate. This is the fundus of the right eye. Again, you see there are some pigmentary changes now. The child is at 16 years of age. Uh, there are some pigmentary changes at the posterior pole that you can see, but rest of the fundus looks grossly normal. And in the left eye also you see some pigmentary changes, maybe some atrophy at the posterior pole, and rest of the fundus is normal. Autofluorescence adds a lot of information in such cases when you are seeing minimal changes on the clinical photograph or clinical examination. And sometimes these children as it is are not very cooperative for examination with your indirect ophthalmoscopes. So this kind of SLO based imaging with Optos and Spectralis adds a lot of information. So you can see much more on the autofluorescence beacon. You can see this reverse Robson holder ring kind of thing where the peripheral autofluorescence is normal and you see a hyper autofluorescent ring and hypo autofluorescence inside it, signifying that the central RP is abnormal with this is the advancing edge kind of thing. And a very similar picture in the left eye. And this is the OCT which confirms that atrophy at the right at the center in the right eye as well as the left eye. So at this point, we made a provisional diagnosis of a cone or a cone rod dystrophy, given that it was a bilateral symmetrical picture, the history of hemarlopia, and so that kept cone and cone rod, counseled for electrophysiology and then genetic testing based on that. So this is the electrophysiology, the full field electroretinogram. This is the patient's dark adapted dim flash ERG, where you can see there is a the B wave is coming very late and the amplitudes are very low in this case when this is a age match control in which you can see a very nice B wave which has come at the same point of time. So the B waves are reduced and that is delayed in this case. This is the dark adapted 3.0 ERG where things start getting interesting, and I'm going to put the normal full field electroretinogram right next to it, and you can see this is the normal waveform where there is a wave going down, reaches its peak, and then there is an ascending limb with the oscillatory potentials leading to the B wave. Here what you see is this kind of flattening of the A wave and prolongation of the A wave, and then there is a very late peak that is coming here, and you can see that it is there in both the eyes, and this gets more amplified when you go to more brighter flashes of light. This is the dark adapted 10-0 ERG where again you can see this kind of box shaped flat A wave, and then there is a very late peak that is coming, and if you compare to the normal where there is a very smooth descent and then the oscillatory potentials on the ascending wave. So this kind of what picture that you're seeing on full field ERG, if you see this is very much pathognomic of only one type of retinal dystrophy that is present, that is caused by the KCNV2 mutation in the KCNV2 gene. So, and these are three kind of pathognomic ERGs described by Robson and Holder, and this is one of them. And if you see this waveform, it is very characteristic. You get a box kind of A wave, delayed peak of the A wave, followed by sometimes an exaggerated B wave, which you can see it is more than what you see in the normal. The amplitudes of the B wave are much more in this case. So that is why this is also called as a cone dystrophy with supranormal rod responses in this case. The cone function expectedly is reduced. The light adapted 3.0 you can see compared to the normal. The waveforms are reduced and so are the flicker which is reduced. So that confirms the cone dysfunction, but the characteristic response is in the rod dark adapted stage which you saw. So we made a diagnosis of bilateral cone rod dystrophy with supranormal rod response, and genetics proved us what we were thinking correctly. And these are cases, though in this case we did a whole exome sequencing. Here you can order just a targeted sequencing for this gene, and this was a compound heterozygous mutation, and when you get these kind of mutations you need to confirm that with the parental segregation so that you know that each of these variants is coming from the two parents separately, which the parental segregation kind of confirmed in this case. So this final diagnosis was KCNV2 associated cone rod dystrophy. Coming to the second case, which is very similar, so I'm going to rush through this. We were more wiser at this stage, seeing the child for the first time at 9 years of age. Again, history of abnormal ocular movements and deviation noticed since 1 year of age. And these abnormal ocular movements, typically in cone dystrophies, you see that the nystagmus kind of improves with age. No definite diagnosis. They have been going around all around and then presented to us finally. This is what the retinoscopy records show, the progression of myopia. Myopia is also a very characteristic finding that you see in this type of KCNV2 retinopathy. Again, born out of a non-consanguineous marriage, had an elder brother who was clinically unaffected, and vision was best corrected, improving to 3 by 60 with minus 5.25 diopter of myopia. Had esotropia and posterior segment, I'll show in the photograph. You can see the esotropia in this child here. Again, color vision was reduced, was able to recognize only the demo plate. You can see the central atrophy more correct clearly in this case, where you can see this pigmentary changes at the fovea, kind of a bronze beaten appearance in both the eyes, and the very similar looking autofluorescence as the previous case with that hyperautofluorescent ring with the central hypoautofluorescence in both the eyes. Again, OCT shows atrophy at the posterior pole. And then when you look at the full field ERG, I'm not going to show you the normals this time, but you'll realize that the B waves are reduced in the dark adapted 0.01. And when you go towards the higher flashes 3.0, you can see this boxing of the A wave that is forming, but 10.0 is which is the most characteristic, which gives you that characteristic kind of box shaped A wave with a late peak and then a high supranormal B wave. So this is something that if you can remember, and if you detect with this kind of history, this can give you a very clear genetic diagnosis. The cone function is reduced, and again, this was proven with genetics to be KCNV2. Again, compound heterozygous and proven coming from separately from the parents. And thankfully, the sibling was completely unaffected, which can be the case in 25% of the cases. So again, KCNV2. So the child was prescribed low vision aids and tinted glasses to make them comfortable. It is a very suitable target for gene therapy in the future, as it is a very small gene, can be packaged into the viral vectors that we most commonly use, and it can be replicated in a very, it has been replicated in a mouse model. And the window period for treatment for this gene can be till as late as 40 years of age. So that is something that is good for developing a treatment for this gene in the future. So just to the take home points, if you can just remember this electrophysiology that I have put up again over here. So it's a cone rod dystrophy, photophobia and low vision are the presenting symptoms. Imaging similar to other cone rod dystrophies as well as the light adapted responses. But the dark adapted full field ERG is something which is pathognomic in this case. And if you can detect this, it helps you in early diagnosis and targeted genetic testing. Thank you so much.
Thank you, Dr.
That's
Singh.
very nice. This you see the structure function dissociation. So the structure on autofluorescence seemed that it's a very tiny lesion in the macula, just like a Stargardt's or just like a macular cone dystrophy. But you see, the ERG showed that the disease is widespread. Even though clinically the retina looked normal, and even autofluorescence, only tiny speck of the retina seemed affected. But see, the ERG told that it's a generalized disorder. Mostly in generalized disorders, it is taught that the vessels are attenuated. But here, the vessels are not attenuated because it's not a rod dysfunction. Whereas in a very classic cone rod disease, which is very progressive, you will see arterial narrowing, RP changes, and a lot of photophobia. But here you see it's a very different mutation. It's a different structure functional correlation. And as you rightly said, the ERG gave us the clue that this is not just a bullseye lesion, macular cone dysfunction. It's a generalized cone disease where the vascularity seems to be not affected. So most of these cases where the vascularity is not affected, they would be sort of stationary. Although he has a lot of disease in the retina, but it may not be progressive. So what is the natural history of these cases? Are they progressive like the typical cone rod dystrophy, or are they like they are bad, but then they are relatively stable?
Yeah, they are progressive disorders, ma'am, and but the good thing is that usually the progression the goes on to beyond 40 years of age. That is
It's
why they say
slow.
that you have sufficient photoreceptors left there to target for gene therapy even at that point of time. So
Yeah, so
all
actually,
throughout the course, multiple phenotypes have been described with minimal affection on autofluorescence to a complete atrophy kind of picture throughout. So these two cases were somewhere in the middle that we were seeing.
This
yeah, I think we
formulation
have
is
also
linked to.
seen very similar cases, and I think what we describe at the fovea is something called the coin-shaped maculopathy, which is again very typical of KCNV2. And as Dr. Simar very rightly said, they are very, very slowly progressive. So again, as Dr. Purnachandran in the beginning said, importance of ERG to recognize it, because the prognosis is much better in these kind of cases. So
Especially in your case, both the cases prognosis is good and reasonable confidence. You can tell that you're not going to go blind. That
Absolutely.
makes huge difference for them. That is also evidence from your genetic testing. Both of them had a compound heterozygous mutation. So, and only thing is vice here, I think first mutation was interesting. It was in exon 1. Though it was a point mutation, it was leading to the termination in the first patient. That's why it's causing the thing. Other will definitely protect. This is even the prognosis even better as compared to the one which is other types which are described in the KCNV2. I mean, this is the beauty. What Subhadra was telling, like you can tell them what's going to happen and all. It makes huge difference.
Is strabismus a common feature of these conditions? Is there some amblyopia happening? There was difference in the refraction, and also, is it a known thing? Because in most of these chondrostrophies or achromatopsia, we don't always see strabismus, but both your cases had different visual acuity and
Both
strabismus.
of them actually presented to our strabismus pediatric opthal and strabismus service, ma'am. But then again, by the second time, we were more wiser, and they were also kind of looking at them differently and sending us early. So yes, in literature also it has been described esotropia is common and myopia is common. Both of these things in KCNV2.
I think the point shaped
Association.
lesions happen very early in life. The
Yes,
earlier you get a maculopathy, the more the chance that you'll have nystagmus and
esotropia. Yeah.
other cone dystrophies. Usually, the child in the first decade may have near normal vision and then worsen. So then they don't have that much of nystagmus. But the early onset ones are the ones where the fixation goes away in the beginning. So you have nystagmus, and coin-shaped maculopathy is a very typical feature of ACMV2.
Right. Thank you, ma'am, and thank you, Dr. Singh. Next, I would like to call Dr. Swati for her presentation.
You are muted, Dr. Swati. Please unmute.
Okay. Yeah. Am I audible? Yeah.
Yes.
Thank you, Jharkhand Ophthalmology Society and Dr. Bharti for giving me this opportunity. Today, I just realized that if I don't send my introduction slide, this is what happens. So I've aged both in photos as well as in profession. So currently, I'm professor at RP Center. So I would be talking about VP. So we move on from retina to something beyond that, which is, optic nerve and the entire visual pathway up to the cortex. So VP, exactly, there are multiple electrophysiology tests, and we have spoken about them very well in previous presentation. Coming to VP, it is basically an assessment of visual pathway up to occipital cortex. And during the process, it actually analyzes the integrity of visual pathway. It sometimes may not be able to localize the lesion, whether it is optic nerve or the optic tract or the visual cortex per se it's involved, but it still gives us an idea whether it's the retinal problem or the optic nerve problem. So that part becomes quite clear whenever we investigate patient with VP. Most common forms of VP that are used are flash VPs and pattern VP. The major difference between the two of them is the kind of the stimulus that we give. So one is a flash, the other is a checkerboard pattern. Flash VP is generally used in kids where we have media opacities, the cooperation is poor, and it is much less sensitive as compared to pattern VP. This is the kind of peak we see for flash VP. So the most important waveform is a P2 waveform. We need to look at the amplitude and implicit time both. For the pattern VP, there's a checkerboard pattern stimulus that is given, and What we generally look at for pattern VP, you can see here, this is a typical normal waveform for pattern VP. What we generally look for is a P wave 100 implicit time, which is at 100 seconds, and also the amplitude of from N75 to P100 is what we need to look at pattern VP. So, and this is the most common investigation that we do whenever we have suspicion of any optic nerve involvement, irrespective of the etiology. So, as I said, if visual acuity is reduced, look at the amplitude, but it could be because of multiple causes. It could be because of retinal causes, could be because of glaucoma, could be because of amblyopia. So amplitude itself does not give us an entire picture, doesn't give any clue about the etiology, but if you have an increased latency, that tells us that there's something wrong with the conduction of the stimulus from optic nerve to visual cortex, and that's how you can differentiate it from the other causes of vision loss. So to begin with, this was a first case, and she's a 32-year-old female who presented with the complaint of sudden loss of vision in right eye, and she had decreased right eye vision with right RAPT. Her fundus was grossly normal. So it's not so difficult to diagnose this case. It's pretty clear that this probably we are dealing with retrobulbar neuritis, and will just confirm our findings of increased latency of right eye. So this is a pretty simple case, and we really don't need VEP to make a diagnosis. What we would need VEP in these cases is probably for two reasons, which will be clear in my next case. So this is again a male patient, similar age groups, eye vision loss in one eye. Again, there is an RAPT presentation. So clinically, you know there's something wrong with the optic nerve, and probably it's again a retrobulbar neuritis. But how does the VEP help us? So there's no doubt about the fact that latency will be increased in the right eye, but look at the left eye. So the latency is not just increased in right eye, both the amplitude and the latency, both at, amplitude is less and latency is increased in left eye as well. So VP is more helpful in such scenario to give us a clue about the subclinical involvement of the other eye. So instead of, it's a unilateral optic neuritis, probably we are dealing with a bilateral optic neuritis there. Also, if you look at the follow-up, it gives us again a clue that, with the time, the amplitude will improve and the latency will also improve. But more than that, is also tells us, because VP takes some time for improvement, it improves later than the visual acuity. So it gives us that if there was any previous attack of optic neuritis before, so even if the vision has improved, it will tell us that kind of history, or will give clue regarding the previous attack. So VP in multiple sclerosis, we have seen that, not only in the affected eye, it will also be affected in the fellow eye of the optic neuritis patient, and will also be affected in the patients of multiple sclerosis, which may not have history of optic neuritis per se. So it's an indirect marker to tell us that the process of demyelination is going on at a very slow pace, but is still going on. And this might help us in understanding, or probably in prognostifying the multiple sclerosis, or monitoring the treatment of multiple sclerosis in these patients. This is another case. This was a 30-year-old female who came to us with progressive decrease in vision in both eyes with persistent headache. Vision in both eyes is very, very poor, and pupils are very sluggish. And you can, very well see on fundus that the entire optic disc looks absolutely pale with gliosis there, and looks like a secondary optic atrophy. The important question which we have in front of us is, should we go ahead and attempt an optic nerve sheath fenestration? The diagnosis is pretty clear. It's a case of raised ICT, idiopathic intracranial hypertension here. And we want to know whether our intervention, surgical intervention, will help the patient or not. And probably that's where the VP comes. Although the response is very, very low there, the peak of the P100 is very less, the amplitude is less, the latency is mildly prolonged, but in spite of that, there is some response that's not totally extinguished, and would like to go ahead and do an optic nerve sheath fenestration there, and we some improvement in, in VP, which corroborates with the improvement of visual acuity there. So in certain cases, it helps us in making a decision for surgical intervention. The next case is a patient, 24-year-old male patient who has been on ATT for almost 3 months and complaints of, not really complaints, he says there is a mild blurring, his pupil is normal, his visual acuity is not very much affected. Although we have a clinical suspicion of ethambutol toxicity there because the patient has been on ATT for 3 months, and 3 months is the time where the possibility of ethambutol toxicity is maximum. So sometimes even if you don't see anything clinically, the VP will give us a diagnosis. Both the amplitude and the latency are affected here in both eyes. So that's a subclinical marker over there that, that toxicity has begun to set in, and this is the time we should stop ethambutol there. Of course, there are other tests also. You can do color visions, you can do fields, but it will take some time for them to present before that VP will give us the diagnosis. So we have this article which was published in BJO and another article again in BJO. Both of the articles have shown that in the VP will show delayed latency even before the patient complains of vision loss or complains of color vision loss there. So it is a way to monitor the ethambutol toxicity along with OCT. This is another case where a 24-year male presented with vision loss in the left eye, and there was a history of trauma to the right side forehead. On examination, there was a right traumatic mydriasis with a left divergent squint slightly there. So we're really confused that, it's the right side where the trauma has been, however, it's the left side which is showing a problem. And unfortunately, we cannot do a consensual reflex in this patient. Otherwise, doing a consensual in the normal eye can give us an idea whether that eye is affected or not. But in this case, because the right eye was a traumatic eye, had a traumatic mydriasis, the consensual was not so much helpful here. So we went ahead and did VP, and we realized that the right eye is still showing some waveform, the left eye is absolutely flat. We went ahead and we did radio imaging, and this is what CT showed. CT shows that there was a through and through the entire fracture line passing through the orbit, probably involving the optic nerve canal as well. So the diagnosis here became clear that it's the traumatic optic neuropathy, which is a problem here. This is another case where a 1-year-old child presented to us, and the mother was very much worried, which she didn't know whether the child is able to see or not see, or what is the prognosis, that there's a history of developmental delay there. So how does VP will help? So if we do VP, we need to do a flash VP here because the child is very small, will not be able to do the pattern. He will not be able to fix there. And you can see that, that's absolutely flat waves there. So again, it will give us a prognosticating idea. VP will tell us how we can explain it to patient and can, rehabilitate them. So it's flash VP, as I said, is helpful in opaque medias, in nonverbal children, in patients who cannot cooperate, in head injury patients where it may be difficult to assess, do the clinical examination. Flash VP is much more helpful than the pattern VP. This is another case where the patient presented to us with one eye vision loss. There is a difference in refractive error there to suggest that there's probably an anisometropic myopia, and the pattern VP in such case is going to show us the reduced amplitude but absolutely normal latency. So this tells us that the problem is at the not at the conduction level, but is at the retinal level or at the amblyopia. So this is what is going to help us in differentiation. So it helps us in understanding that the vision loss, is it functional, is it malingering, or is it actual organic lesion there? So it will be, if the normal VP is there, you can be sure that the patient is that the vision loss is functional. There are other types of VPs. You can have sweep VPs, which will help us in measuring the visual acuity in children, because the checkerboard pattern, the size of the checkerboard keeps decreasing and will help us in estimating the visual acuity in children. The another type of VP, although not so commonly used, is a multifocal VP, and the major advantage that it will help us in a localization, whether it's a central lesion or a peripheral lesion or a sector-wise topography of the ganglion cells. So to conclude, that VP will help us in either early diagnosis or the subclinical diagnosis of optic nerve lesion. It will help us in progression of the disease, particularly in monitoring of the treatment, particularly in cases like multiple sclerosis, we are suspecting demyelination lesion of central nerve system. It also helps us in differentiating the retinal pathologies from optic nerve pathologies, also helps us in differentiating from non-organic to from organic and non-organic vision loss, and is useful in determining visual potential in non-cooperative patients. But we should at the same time remember that has its own limitations, not that the VP is all in all. You have to see, like with any other investigations, be it electrophysiology or OCT, you have to see it under the proper clinical examination and history. There is no substitute to the proper history and clinical examination, I would say, if you want to interpret any of the electrodiagnostics test. So it will get affected by the poor vision, by the poor refractive fixation, by the refractive error. It may not give us the exact localization of the site of the lesion, and will have a limited role in the macular diseases. With that, I would like to thank Jharkhand Ophthalmology Society. Thank you.
Thank you, ma'am. That was an excellent talk, ma'am. Thank you very much, ma'am.
Thank you.
Dr. Rahul, I have a very pertinent question here.
Yes,
Can
yes,
I?
sir. Yes, sir. Please, please, please.
Madam, what is your take about the vision and the type of VP that you're going to do? Is the flash VP or a pattern VP?
So generally in adults where the vision is where the patient can fix, we would go for pattern VP if the patient can fix and is cooperative. In patients who are not cooperative, cannot fix, flash VP is a good idea.
Visual acuity is no issue?
Visual acuity is say around, I mean, because the pattern VP usually is has a stimulus size of 4/60, 5/60. Anything beyond that, it may be difficult to do pattern VP.
Thank you.
Ma'am, can I ask one question?
Yes, Siddharth,
Yeah.
please.
Actually, regarding this, kids with CVI, we have so many children with CVI who come to us, and invariably the pediatricians are advising them a VEP, and most of them would show visual pathway dysfunction, but with refractive correction, their visually directed behavior really improves. So, do you think is it over prescribed advice to them to do a VEP, or what is the role in those cases?
That's a little difficult. From their point of view, probably they want to know that, whether the cortical function is intact or not. Probably that's the reason why they advise. From our point of view, probably it doesn't help in so much, because I've seen patients who have had extinguished response also at presentation have improved gradually with the proper treatment. So I think from pediatrician point of view, probably they want to know the response and it helps them in understanding. I think that's the reason, but I do agree with the fact that probably they are overdoing it.
I just want to add to that I think there is a lot of disconnect between what we are learning about developmental eye care of these children versus what the neurologists or the pediatricians ask for. They are not aware that there are newer techniques and technologies now. I think the most useful thing that I have found in last 10 years is what we are now just marketing. It is called BAVIS. We have a stake in that. This is a pediatric perimeter which can actually tell you exactly which meridians the child is looking at, even as young as 6 weeks or 8 weeks or even 2 months. And especially in CVI patients, now this is called baby vision screener. It was initially called as pediatric perimeter. It will be marketed by Forus company. So this is a very useful device which can actually tell you which meridians the child is fixating, where it is looking, is it looking or not. So that is going to be really helpful. It's just like, the fields are more useful than just a VP, let's say in a patient who has glaucoma. Or a pattern ERG, because it's the visual field which decides whether the patient is going to see or not see your work. So previously we didn't have any visual field marker or a developmental test for babies, because this happens so often that even we are not able to, sort of evaluate in that short clinical period, is the child seeing or not seeing? Because sometimes you just put the light and the child just closes its eyes or looks down or doesn't have neck holding. So how do you test these patients whether they are seeing or not seeing? Because that is the question the parents want to know. So I think this, it will be good. Everybody can look at it in the coming AIUS and other places, that it's a real remarkable change. Why the neurologists and pediatricians are asking for PEP? Because they have no other way of testing the vision. But even without the BABIS, we already had, preferential looking tests and, the functional vision with, in a dark room, if you put lights, you can make out. And especially colors, even severe CVI patients will be able to see colors. Colors is very robust. So we have other tools which are checking the functional vision. But I think that information and knowledge has not been shared with the pediatricians and pediatric neurologists. So they only know about VP. And I think VP is, except for sweep VP, maybe, which is a little better in cooperative patients. The other VPs, may still be extinguished and child may still have vision. So if the VP is good, it gives you reassurance. But if it is not good, don't tell the parents the child is blind and will not see. This is a very, very important caveat. Even before testing, we tell the parents, because the moment the optometrist or the technician writes absent VP, the parents don't listen to anything that you're saying. They just have that report in hand and they're so depressed that they're not listening to you when you say, an absent VP is not absent vision. So these things should be counseled before the VP test is done. That if it comes absent, don't worry. There's still, methods to evaluate.
Jalali
Yeah.
madam,
Okay.
one question. What is your take the effect of anesthesia when you're doing VP?
So I
Anesthesia?
haven't done VP under anesthesia. We do have the handheld. Tapas, you have any experience, or Purna? Mostly we are doing
We used
ERG,
to do,
but
we
flash
used to do
VP
a
we
lot
can
of
do. But
we used
I don't know.
we,
We
we
use
used to do
sedation
earlier.
instead
We
of
used
full anesthesia. We use sedation. So we give patient weight. According to weight, we give them sedation with pedicloral, and that helps.
Actually, the
we
general anesthesia will suppress the VP a lot.
Yes.
So it is not
exactly.
recommended that you should do
Yeah.
VP under general
We used to
anesthesia.
do a lot of VP and ERGs and anesthesia, and we have stopped since last 8 years because of the reason what Parveen ma'am just mentioned. So,
But
and
Praveen,
pediatrically,
they are saying that you can use VPs when they do brain surgery under GA to monitor, or
you
the
you
orbital
can.
surgery. Orbital surgery, they will monitor sometimes
So
VP,
what you
brain
can
surgery.
probably they look at is interocular difference in VPs, not to measure whether it's present or not,
Yeah,
but
and
they
maybe
will give
those
a
patients have normal VP to
yes,
begin with, and
begin with,
they're just looking that it doesn't go away, or they're not cutting the optic nerve, or they're not
and
injuring the
it
optic
doesn't
nerve.
get extinguished at
Yeah,
any
by
point of
GA.
time.
Yeah,
So that is a different indication
yes,
altogether. But
yes.
to prognosticate and tell whether the optic nerve disease is present or not, that you can't use.
Correct.
It's
I
extremely
agree.
technician dependent, ma'am. I think if the
Not only
technician has to
technician
be really
dependent,
smart to pick
uh,
up. So
the,
that's why
the
whenever
anesthesia agent which you will use will differ the kind of response you will get.
no,
So
anesthesia to no, I mean we have completely stopped doing it on anesthesia. Even sometimes we try doing it in the awake children's. The technician is smart and all the still they can get, but I don't rely on this one as you rightly mentioned.
I
Whenever
think sedation
pediatrician
itself is good enough. You actually don't need anesthesia
So
in
I
the
think, Praveen, what you're saying and what the panel is saying is that uh, don't give anesthesia when you're diagnosing something, But if you are monitoring something, that something is there and is it going down, and you're monitoring something, you could use, as they do during brain surgeries or orbital surgeries, where you have a normal response and then you're looking at it's not changing due to anesthesia. The opposite is not true, where you don't have any idea what is the response and you're giving anesthesia, then it could just make a mismatch between the truth and what you're getting, because the anesthetic drugs would affect that.
Now, Purna, you got a task here. Purna, you got a task here. The effect of different kind of anesthetic agents or sedations onto the VP. You gotta do
No,
that.
sedations, to be
Lot of
frank,
literature
we are
says.
not looked into, the effect of short sedation. To be frank, I don't have an idea. We stopped, but as Subhadra ma'am rightly mentioned, whenever I get reference from pediatric neurologist for VEP, I just tell them you have better method, go why you want to do VEP and all. It will only go add to the confusion. If it's abnormal, you're not sure whether it's abnormal. So why you want to do it
Actually,
when you have better things?
you can very easily do a flash VP in children. It's not a problem. Even
Not
a
a flash
very
VEP
young
is not.
child also, while the child is lying in the mother's lap, you can do a flash VP. And pattern VP anyway is impossible under GA because the child cannot fixate onto a pattern. So, and
Most
flash
of them,
VP has a lot of value, just like Dr. Swati said. For optic neuritis, probably there is no other way of following up children other than a flash VP, because you can't do fields and you can't do MRI again and again every 1 month, every 2 months, every 6 months. You can't do MRI to look for the response to therapy in optic neuritis in a child. And this is a totally non-invasive, simple technique which can be done n number of times to see whether the child is responding or not. And optic neuritis in a child is totally different from that what you will see in an adult. So I think the flash VP is very useful there. I think Dr. Swati will also probably vouch for it that
I definitely agree with you, Dr. Same there, because even though in adults it may not be so useful, but in pediatric cases definitely has a role to play. And even in CVI cases, ma'am, Dr. Subhadra, as you said, we have baby screener there, but that will also need, I feel, some kind of fixation. So in patients who do not have any fixation, or do not have any kind of vision there, probably VP still has a role to
So
play.
Bavis is used where there's no fixation.
Yeah,
Bavis,
but
when you see that instrument, it
yeah,
it
I
doesn't
have,
require
ma'am.
fixation. Yeah.
Yeah,
If
I
they
have, and
don't
I've
fix
received
it,
it
even
through
if they have
LBC.
nystagmus, they have, no, poor neck holding. So let us see. More data is being collected.
Yes,
So
ma'am. Yes,
it
ma'am.
can be used even in, older children or even in adults who cannot sit or
I'm
who
sure.
have
Yeah.
mental retardation. So let's see. Okay, we can go to the next because we
Thank
have to
you.
go home.
Yeah, thank you.
So,
Thank you so much.
for the concluding talk for today's evening will be given by Dr. Tapas Ranjan Pari, and he will be talking upon the retinal function in babies treated with intravitreal anti-VEGF for ROP. He will be sharing his insights for fulfill ERG. So,
Good evening, all. Am I audible and are my slides visible?
yes, sir, it's audible and it's
sir.
visible.
I express my heartfelt thanks and gratitude to the Jharkhand Ophthalmic Society and Dr. Kashyap, and to chip me in this in the galaxy of expert speakers here to present before you this important talk: retinal function in preterm children with a history of retinopathy of prematurity. I will be discussing our report number 1 in the form of form of a study. So, does intravitreal antivascular endothelial growth factor affect full field electroretinogram? So, this was my question, because we know that the anti-VEGFs have rapidly gained popularity and slowly become the treatment of choice in many forms of retinopathy of prematurity. Now, there have been concerns on whether the agent affects the retina and as well as other body organs. So, in this study, we had an intention to see whether the anti-VEGF is affecting the retinal function significantly or not. And we thought full field electroretinogram with the different waveforms that was discussed by Dr. Purna, and a very good tool to assess the photoreceptor changes and their connections following intravitreal anti-VEGF. And here we would be restricting to bevacizumab half the adult dose. But there is a caveat here. The doing ERG, as we not only VEP, the doing ERG in infant and children is a challenging task. I remember that maybe 7-8 years ago, I used to struggle to do them under general anesthesia, and so could do only few cases. And because so many things affect the technique, the type of the setup we have, the protocol we use, whether we are using sedation, anesthesia, no anesthesis agent can have a significant influence. They can dampen down the ERG, VEP in any electrophysiological test that we do. And the importance of gathering normative data, because these tests, the values differ significantly depending on many parameters. If you don't have a normative data available to compare, then the reproducibility and the significance of the test goes down. And of course, we are dealing with a disease where the prematurity can affect. The disease retinopathy of prematurity can also affect the ERG and might come out as a bias for assessing the effect of bevacizumab on the retinal function alone. Now, the instrument that we have used has had certain advantages to carry this study, and this is nothing but a small handheld device, Retival from LKC Technologies, with skin electrodes. This could be used easily to do test on awake infants. So it's awake ERG. We can see that these are the advantages. It's fully handheld and easy to use instructions. There is a camera, and they have this device is ISAF compliant preset protocols, and no sedation, no anesthesia needed, because these here the electrodes that are used are skin electrodes. As you can see here, this electrode itself contains both the plus and negative poles. The plus, and this stays starts from the lower lid and extends temporally. Now this is connected to the recording device, as you can see here. While the first one is done under general anesthesia, the lower one you can see that it can be very easily done in the awake stage. This study was done from 2019 to 2020. Those babies who were treated with intravitreal anti-VEGF, bevacizumab for ROP, and the ERG were included in the study, and the ERG recording was done with the Retival devices. And these are the ones where we these cases we excluded, the ones listed down. Now the after eligibility testing, parental consent was taken, and the demographic details, the age at evaluation, refraction, and was noted. ERG was done with Retival with central step electrodes, as we saw in the awake stage. Analysis of the ERG waveforms were done in terms of the amplitude of the individual waveforms and their latency, both in the scotopic and photopic stage. Because, and this is in brief the results. We can see that like there were total of 72 patients, 137 eyes, and these included 9 subjects that had self-regressed ROP, and 63 patients where intravitreal bevacizumab done was given for RP. The age ranged from 6 months to 2 years, and These are the other profile. We can see that the groups differed in terms of self-regress group as well as those who underwent intravitreal anti-VEGFs with respect to gestational and age and birth weight. Now, this is the plot. Here we can see that those who were treated versus self-regressed ROP, those preterm, very preterm, and those who are treated as well as self-regressed, we saw that there is not much trend. There is considerable overlap, no directional trend. So neither with prematurity, nor with ROP severity, nor with injection. These are the values, mean and standard deviation with respect to now in both the groups, that is self-regressed as well as treated group, and individual waveforms, dark adapted 0.01, dark adapted 3.0, light adapted 3.0, and light adapted flicker. And we saw that we could, as is seen here, if you look at the p-value, almost all of them were not statistically significant. The difference between the two groups were not statistically significant in almost all, except in one or two waveforms, amplitude in the B wave amplitude, and again here the A wave implicit time. Otherwise, most of them, there was no significant difference. We did a multiple regression analysis, and in this multivariable regression analysis, we found that the age at the test came out to be the significant association with the ERG rather than the treatment. So that means compared to the severity of the ROP, the type of treatment, and other parameters, the one that affected the ERG was the age when we are doing the test rather than these factors. So this tells us that in this study we observed that the intravitreal anti-VEGF were not found to have significant effect on the retinal function as seen in the full-field ERG. Now, the scotopic and photopic functions, they catch up with age. And I remember that in our first case, when I did ERG in just 6-month-old child with the general anesthesia, I saw that the responses are almost non-recordable. I thought that probably ERG is getting affected by bevacizumab, and it is causing significant effect on the. But the same one individual, when I recorded the ERG again, and I found that the responses have come up. So the limitations include technical difficulty in awake ERG in babies from 6 months to 2 years. Doing is, unless it takes some time, but with the handheld devices available, the responses can be analyzable, like the way we did in 72 patients that received, including those who are self-regressed and those treated with intravitreal anti-VEGF. There are issues with control. Now, getting control, a huge issue. We used the normative data that is available with the device up to 1 year, and below that we used our own normative data. But then in an ideal situation, one should use the normative data from their own lab. There is a need that this should be studied further, and it would be good to see how this ERG change over time. Now, at what age they catch up, and This is the study, this is something that need to be studied and with proper normative control. So I conclude here with giving you a message that the intravitreal bevacizumab was found not to affect the fulfilled ERG in this study. Thank you so much for the opportunity. I can take up any questions or comments.
Yes, Dr. Vibhuti. Dr. Vibhuti.
Hi, good evening, everyone. Good evening, Tapas sir. This is Dr. Vibhuti Kashyap from Ranchi. A very excellent presentation, and I've seen this presentation before also. Sir, I just wanted to ask one question. Do we also expect to see, or is there anything that leads you to suggest that there may be differential responses of ERG recovery, or any changes or differences in the ERG of babies treated with bevacizumab versus a ranibizumab?
If I may add one more question, and you can probably answer both together, Tapas. Since we have used bevacizumab a lot in adults, any hypothesis that you had in mind that the children would probably be more affected by bevacizumab as compared to adults? And same as Dr. Vibhuti said, would they be more affected to ranibizumab as compared to adults? In babies, retina would, or a premature retina would be more susceptible to toxicities. What I'm just thinking loud. Of course, a very difficult study which you have done very well. Nothing to take away from that.
Yeah, also I've not compared, but what I could see in these 63 subjects with intravitreal anti-VEGF, I did not find intravitreal bevacizumab permanently affecting the retinal function. Just the ERG changes, that is seen, say, if I have examined this preterm infant with ERG at 2 years, then vis-a-vis a normal individual or not full-term baby with 2 years, the ERG amplitude and the latencies, everything is less. But then if I later on, after few years, if I check, both of them become normal. So there is a decrease, but it is not, it catches up with age.
There are
So
lots of confounding factors, basically. Very difficult to do this kind of research.
Study.
Very, very difficult because the zone of ROP, the stage of ROP, that itself may also affect vascularized, how much is vascularized, how much is not. And I don't think there are many studies which affect the, which look at the effect of gestational age on the retina, on the ERG. So we don't know whether that itself may also do.
I mean, that has a lot of data by Anne Fulton and also Dorothy Thompson's group in UK and Boston, Boston and UK respectively. They have done a lot of studies and they've shown that, there are stunted ERG because they are stunted photoreceptors in normal preterms, even without any ROP. And then, of course, with ROP it changes. But I think what this study has really done is that, first it has shown feasibility that we can do reliable ERGs in children. And our main concern is that whatever is the baseline, is there toxic effect of this drug? Is it showing something very remarkable, which is different from what has been reported in normal children? So, so that is a useful thing to
Was
to
that whether
know
an
what is
immature
happening.
retina would be more susceptible to toxicity vis-a-vis an adult retina.
Yeah, so that is sort of the null hypothesis that it is not. And so at least this data shows that although they may, like all other functions in preterm babies, they catch up. They catch up and things
Mother,
are improving, but we need more data.
just a thought process. I don't know whether it will be possible, whether you can do ERG before injection and after injection.
Yeah, so that's what that's what is our second study in the next phase, that is report
Ma'am, you are
2.
muted. Subhadra ma'am, we'd like to hear what you're saying, but you're muted.
Yeah, I was just saying, see, we have been giving anti-VEGFs in AMD patients, millions of doses, right? Those are degenerated retinas, and we are giving all these anti-VEGFs. They have shown some atrophy, but see, these children, although they have an immature retina, but it's not a degenerated retina. It's not undergoing degeneration. In fact, it is undergoing developmental improvement over a period of months and years. So the vascularity is improving, the function is improving over a period of time. So they are not undergoing a degeneration. So I'm not thinking that the drug would, adversely affect these retinas in terms of their photoreceptor function.
But if you
Two
do before
things.
injection and after injection, it'll take away the confounding factors of
Yes.
the stage of
Yeah, yes.
ROP on the ERG. That
Yes,
would
and we can do it
really
along with the
be.
OCT. Now we are able to do oral fluorescein
And
OCT,
it's non-invasive.
ray-free.
It's non-invasive, so it should not be a
Yeah.
issue. Anyway, the child has to come for a follow-up also.
Yeah,
So
this is our next phase project, but I would like to share two things. One is many of these babies now have grown up. So actually, some of the cases I have done these ERGs of these babies who have received anti-VEGF at 10 years and 12 years. Believe me, all of them have become normal like their age-matched counterparts. So not only during this study, 6 months to 2 years, but outside this study, I have seen that babies who have received anti-VEGF, those who have grown up 10, 12, 13, so they finally it becomes normal. And though ranibizumab was not included in this study, there was a question. Don't see any difference on the retinal function then with ranibizumab and bevacizumab, but this need to be studied and with the adequate scale, not just looking at the ERG patterns, just as a whole what we see in the prints.
great work, Tapas, stimulating to the mind. Thank you.
And actually, I can the what was interesting to me is that I had a child who was treated with intravitreal anti-VEGF in one eye and a laser in the other eye, which I have been following up for last maybe 12, 13 years. So the anti-VEGF eye was did not come back, recur again, except a small strip of peripheral avascular retina, and the laser was done the laser was done in the beyond zone 1, and I did both the ERGs in both the eyes. There are slight differences, but nothing much. I was expecting that a huge difference between the between the eyes, but then again, maybe that was laser, which was anterior to zone 1, maybe zone 1 posterior diseases lasered would affect the ERG and would show up a difference than those who are treated with anti-VEGF. That need to be studied.
More than 50% of difference has to be there minimum to get you a change in ERG. That's the problem. It's a
Yeah.
mass response. But if you probably do a wide field multifocal or something like that, then you may do a 4-sector ERG. Then you may get some difference between temporal and nasal or something like that. I think we are going beyond the scope of discussion here. Yeah.
Thank you, ma'am. Thank you, sir. Bharti ma'am, are you there?
So now we are concluding the session, and Jharkhand Ophthalmological Society is highly grateful to our electrophysiology speakers, which is a very focused talk and little separated from the normal vitreoretina practice. Dr. Purna Chandra, Dr. Parveen ma'am, Dr. Simar, Dr. Swati Pooljale, and Dr. Tapas. And Dr. Tapas' comparative study was very enlightening, and above all, Dr. Subhadra Jalali madam. She has taken the course to a next level, and actually it was a master class of a mid-level, but it turned out to be a very advanced level electrophysiology session. And for this, we are highly indebted to all the speakers and our star discussant, Subhadra Jalali madam. and all the discussants, local Jhos discussants who stayed till long, till 10 p.m. and they all are listening to all the speakers. Siddharth, you have to say something. He's a VR surgeon from GNEC. He looks after the pediatric clinic.
I was actually, it's a very enlightening talk, and I was listening to all the speakers, and I've learned a lot. That is all I would say. Thank you.
I only want to say I didn't do any work. All the work was done by Simar, Puran, Swati, and Tapas. I really enjoyed, and Praveen, of course, because every time we hear, no, we are learning because these are new areas, new frontiers. I think most of us
Madam,
are
you are
still
not
students.
visible. Your camera has become off.
Okay. Okay, I'm here only. No, what I was saying is that we are all students in this game because the material is less, the experience is less, the opportunities to learn is less. And so it's really good that Jharkhand Ophthalmic Society clubbed electrophysiology with cataract. Cataract, everybody's expert. But here we
Ma'am,
are.
only three talk, 4 minutes each, and the
I'm
entire
just saying,
Jharkhand
so really
Ophthalmological
thankful to
Society was
you
asking
to
question 1 hour.
help us to learn with each other. And thank you, Swati. I think I'm hearing you for the first time.
Yes.
So it was really, really enlightening to hear you and know the great work you're doing.
Thank you, ma'am. Thank you so much. Thank you, Dr. Bharti, and thank you, Jharkhand Ophthalmology Society. It was a pleasure. It's a great meeting, and I also learned a lot of things about ERGs, multifocal ERGs, and it was great listening to all the speakers there. Thank you.
Thank you very much. Thank you. Thank
Bye.
you, everybody.
Thank
Bye.
you.
Bye, madam.
Bye bye.
Bye.
Good
Good
night,
night,
madam. Thank you so
everyone.
much.
Madam, a special thanks to you, Madam Raj Jalali.
Thank you. Thank you. Everybody
Also,
remember to vote for Vibhuti.
all the best, Bibhuti.
Oh, so
All the
sweet,
best,
madam.
Vibhuti.
Thank you so
Best
much,
God
ma'am.
with
Thank you
you.
so
जितने
much. I
ज्यादा
will not.
रेटिना सर्जन्स टीम में है उतना अच्छा है। हम रेटिना सर्जन्स को चाहते हैं।
Vibhuti is also an
Thank you so
ROP
much for the
expert
support.
also.
Yeah. Okay, bye.
Night.
Bye bye.
Bye,
Good night.
Purna.
Good
Bye,
night, everybody.
everyone. Bye,
Good night. Good
Siddharth.
night. Bye bye.
Good night.
Bye, sir. Bye, bye.
Bye.
Good night. Bye, man. Bye.
Bye. Bye, everyone.